مرحبا دكتور.
أهلا أهلا أحمد، صباح الخير.
صباح النور. أنا
كل شيء
وأنت لسه على أول السيشن.
أوكي. أنا كتبت له بس شكله هو أول آخر شيء واحد أو ثلث. بس لا هو ما انتبه على التوقيت. ما
مم.
معقول لا. بس حكتب له مرة ثانية. شوف، أنت
إن
عندك
شاء
رقم
الله.
التليفون تبعه؟
هو بعت لي على الإيميل.
أوكي. زين، شو وقت تبتدي نفتتح؟ الساعة 9 صح؟ لو قبل التسعة أحسن نبتدي.
لا، هو دلوقتي الساعة لسه فاضل 10 دقايق.
أي بس على مود قبلها 5 دقائق نبتدي نشرح عن
بنتكلم.
برنامج اليوم. إيه؟
أما شيماء بس
وبعدين
أتأكد اللي هي إن أهي برن
تأكد.
عليها.
إيه؟
ألو. الحمد لله كله زي الفل. 9. مم. مفيش مشكلة. بس خليكي بس سريعة لأن إحنا بادئين بس. خلي المستشفى ابعت لهم اللينك يعملوا لك جوين ولو جهزوا البرزنتيشن بتاعتك. اوكي. بس يلا سريع. يلا.
يلا ساين ان. أحمد، كيف الأخبار؟
تمام دكتور، هو دكتورة شيماء لسه مكلماني اهي، هي داخلة
إيه؟
قدام 5 minutes تبقى في المستشفى
أوكي.
بتشيرني هناك يعني. أنا كده كده معايا محاضرة أحمد الشربيني مسجلة،
جيد.
و رباب عبد الوهاب أعتقد اللي هي هتبقى إن يعني.
أوكي.
السيشن التانية هتكون دكتور عامر ودكتور علي
تمام.
الحمداني.
أوكي.
وأحمد
فإذا إحنا
السباعي على تواصل، أنا لسه معاه دلوقتي، وريتشارد أكيد هيكون إن، دكتور سلام ونجاح الزياني دي بس تواصل معاها ما شفتهاش يعني خالص.
بكتب لها. أوكي. تمام.
إحنا هنبدأ 9 إن شاء الله وننتظر شيماء، لسه فاضل 7 minutes يعني.
إحنا نقدر على ما يصير حضور افتح أنت فتحت الساين إن؟ في أحد دخل؟
أنا لسه ما دخلتش، دخلت الأودينس. الزوم
بس هو
دلوقتي
كان.
عامل أبديت جديد اللي إحنا البانل ليست يدخلوا من الأول
إيه؟
وابدا احوله اللي هو allow الاودينس اللي هم يدخلوا.
مم. كم عندك دخول؟
لا احنا في البانل ليست لسه ما اشوف الحضور، لازم
ما
احوله
في.
للساين ان.
أوكي. زين، سوي ساين إن لو إلا ننتظر الباناليست كامل.
خلينا بس دكتور ننتظر نبدا 9 شهر لحد ما نشوف شيماء.
ما راح يضيع الوقت علينا احنا. على ما نبتدي ونشرح عن البرنامج تاخذ شوية 5 minutes. تكون
انت
دكتورة شيماء.
موليناث وشيماء هم اللي بيشيروا السيشن.
أعرف أدري. بس مو إذا ما أجوا أحد شلون؟ أنا يعني أسوي أنا دكتورة شيماء we will join together.
ما فيش مشكله.
هذه نفس الشيء طلع يوار إن براكتس سيشن.
ايه، ما هو وانس اللي انا اضغط ستارت ويبينار من عندي بيدخل الاودينس.
إيه أوكي.
انا خايف بس ان شيماء تتاخر شويه، فانت ما تقدمش شيماء لما تكون داخله.
إيه طبعا طبعا، بس ممكن أتكلم عن البرنامج مال اليوم.
طيب يلا. بسم الله ما شاء
دقيقة
الله.
بس أفتح البرنامج عندي. آه
ظبط
بال...
وقول لي ستارت يلا.
اوكي. اللي هو لينك فور بروجرام صح؟
ايه.
اوكي يعني فتح عندي. بس احتاج ادخل هسه.
يلا اوكي.
يلا. Good morning, ladies and gentlemen. Today is the third day for IMDO conference. Thank you for joining us. I will just start to give a summary about today's conference. There will be three sessions. First session will start at 9 o'clock. Will be chaired by Dr. Molina Banerjee and Dr. Shaima Abdel Mahmoud. First lecture, it will be about SGLT2 effects in heart failure and other lectures. The second session will be chaired by Professor Al Hamdani and Dr. Amr Ad-Dirazi, and it will talk about the bariatric surgery, while the third session will be chaired by Dr. Huda Umran and Dr. Abir Al-Yafi. And there will be different aspects of important lectures. One of the speakers will be Dr. Ahmed Shirbini and Dr. Richard, Dr. Salam Jibril. And I hope today you enjoy the program. So first of all, I will try to introduce the chairman of the first session, Dr. Molina and Dr. Shaima Abdel Mahmoud. Well, Ahmed, we can get the CV for the doctors.
You can read from screen, doctor.
Yes. Okay. So Dr. Shaima Abdel Mahmoud, she's a senior cardiac specialist in the Salam Specialist Hospital, Master Science in Cardiology at Shams University, worked as a specialist cardiologist at Adult Catheterization Lab Unit, EPS Catheterization Lab Unit, Congenital Structural Catheterization Lab Unit, CCU, ER, non-invasive lab, invasive lab also of echocardiography and stress cardiac unit. Dr. Sheima, she's part of our scientific committee for the current the IMDO and the previous 5 editions of IMDO. So she will talk, in the first lecture, she will talk about important topic, which is the SGLT2 effects in heart failure patients. So you know that this group of medicine, which is SGLT2, show good control and good evidence for control of the sugar, besides the reduction in the cardiovascular mortality and morbidity. So further studies have been focused currently about this effect on the heart failure patients. So Dr. Sheimashi will talk about this topic. We are waiting here to join the team. Then the second chairman is Dr. Molina. Dr. Molina Banerjee is a consultant physician and clinical lead in diabetes endocrinology, weight management, and general medicine. Divisional research lead for acute adults. Division Bolton NHS Foundation Trust. Another clinical lecturer in endocrinology and diabetes research group, University of Manchester, United Kingdom. And then he had a PhD from Manchester University following a successful grant received from British Heart Foundation. He had led the quality improvement projects and published peer-reviewed articles in various journals of diabetes and endocrinology, associate editor of the British Journal of Diabetes and clinical champion of diabetes, UK. Dr. Shaima, she's in.
Dr. Shaima prepare herself, Dr. Asad, just 1 2 minutes.
Okay. So we will give a chance for 2 minutes for Dr. Shaima to prepare her presentation, and then we will start the first session. Regarding the question and answer, you can type your question and answer in the here and down, and then also you can raise hand through the Zoom also to ask a question directly.
share screen. Do you hear me? أنا بكلمهم هم
Good
بقى كده
morning,
سامعيني
Dr.
ولا؟
Shaima.
Yes, okay.
We hear you.
You can
Okay,
share
now.
the session, Dr. Asad.
السلام عليكم. Turn up volume.
Yes, Dr. Shaima.
السلام عليكم، ازي
Uh,
حضرتك يا دكتور؟ معلش اسفه التاخير. I'm so
that's
sorry.
okay. You can start your lecture with Dr. Shaima. She will present the first lecture, SGLT2 effects in heart failure patients. Dr. Shaima currently working in Assalam Specialized Hospital. She is assistant lecturer in senior cardiologist, and she has the PhD cardiology from Ain Shams University. Okay, Dr. Shaima.
Welcome, doctor. I'll talk about SGLT2 inhibitors and get to heart of diabetic patient. My approach today that the heart failure is a worldwide burden disease, and it can affect mostly of the patient of overall world, and the inpatient care is about 60%. So heart failure is a huge burden. 1 in 5 people develop heart failure. Number 1 cause of hospitalization in people more than 65 years old. And about 30% of those admitted to a hospital are readmitted within 3 months, about 90 days, and about 30% die within 1 year of hospitalization from heart failure. A huge burden, heart failure disease can cause approximately 50% die within 5 years. There is a heart failure is associated with reduced quality of life and leading to a greater risk to the hospitalization risk of hospitalization. And as we see here, more than 1 million annually hospitalized in both in the United States and Europe, and up to 9 over 10 patients hospitalized due to worsening chronic heart failure as compared with de novo heart failure. And about 1 to 4% has heart failure hospitalization percentage of the total hospital admission, and 5 to 10 days there is average length of the hospital stay. In addition to cardiovascular outcome, heart failure significantly reduces the quality of life and causes high symptom burden on a daily basis. So we find very important numbers as we see here. 76% to find it too difficult to carry out usual activities, and about 66% have mobility problems, and about 68% report some kind of pain and discomfort, and 50% have anxiety or depression, and 25% struggle to take care of themselves. So improving of heart failure symptoms and the quality of life continue to be an unmet medical need in patients with heart failure. There's then from this figure we can find the life expectancy in US in HFrEF patient, and with moderate range heart failure disease patient. As we see here, life expectancy is better in HFpEF patients than the HFrEF patient. Cardiac function decrease with each hospitalization. So from acute event to then remission, then again suppression in the state, and often there is additional myocardial damage with each hospitalization, which can affect the cardiac function of the patient. What is the link between diabetes and heart failure? Is it interlinked? Yes, diabetes and heart failure has a good link. as diabetes present about 30 to 45% of patients with chronic heart failure, and they have reduced with or preserved ejection fraction. Diabetes mellitus increase hospitalization and morbidity in HFrEF and HFpEF patient by 75%. In heart failure patient, they have four-fold higher prevalence. In type 2 diabetes mellitus, about 20%, and this raises to 40% in type 2 diabetes mellitus patient and hospitalization from heart failure. Also, metabolic impairment is intrinsic to the heart failure and pathophysiology and insulin resistance and present up to 60% in patient of heart failure. This is the pathophysiology of diabetes mellitus and heart failure overlap. As we see here from the diabetes occurrence, obesity, and increased lipogenesis, gluconeogenesis, and increased insulin resistance, it will make hyperglycemia and make for the patient sacroiliac stiffness and causing like comorbidities in the heart muscle like LV dilatation, myocyte necrosis, and myocardial infarction, and causing HFrEF to the patient to reduce the ejection fraction. And also it can cause inflammation, fibrosis, endothelial dysfunction, and LV restriction, which can cause another pathology to the heart, HFpEF, heart failure with preserved ejection fraction, and cause all symptoms of heart failure for the patient. So it will cause all morbidity and mortality on the heart, and it can cause sympathetic activation and race system activation. So it's the role of SGLT2 inhibitor to decrease this and can play a good role in preventing heart failure, rehospitalization, and heart failure symptoms. Treatment goals for this patient with heart failure, as we see here, we will need to improve survive and prevent hospitalization, prevent relief symptom, and improve quality of life, and increase the functional capacity of the patient. Current heart failure medication per guidelines, as we see here, step 1 is medication for heart failure with reduced ejection fraction, assess volume, and initiate good glycemic control. And step 2 is consider to the following patient scenario according to NIHA class presentation and create clearance. Is it more than 30 or no? Is the patient is started ARB or ACE or no? And then if the patient is black patient, so we'll add like hydrolyl nitrates, or a patient is NIHA class 2 or 3, but LV ejection fraction less than 35%, so survival rate is very low, so or post MI, we can put ICD for them, or NIHA class 2 to 4 with LV ejection fraction less than or equal 35% with good QRS complex pattern with left bundle, we can do for them CRTD, for example. And if the patient is more than 70 beat per minute, we can add ivabradine, for example. So it is my step 3 to optimize the medication for them to reduce the symptom and the quality of life. Step 4, we can go for refractory cases like NIHA class 3 or 4 stage D, and we can do for them step 2 treatment as considered as palliative care and CRTD or LVAD or investigational studies for them. So unmet need in heart failure medication, prevention of heart failure in individual with risk, and the disease modifying therapy as reducing mortality and improving prognosis of heart failure, and the convening therapy for the option 2 for the patient like heart failure with preserved ejection fraction and managing cardiorenal syndrome. There remain urgency to improve outcome from the patient with heart failure. So despite all of these guidelines, there is usually rehospitalization, and we should decrease this rehospitalization risk for these patients because about 50% of the patient from heart failure can die within 5 years. So the universalist definition for heart failure classification nowadays, according to phenotype, according to ejection fraction by echo, we divided it into 3 categories. Less than 40% is called half-RAF, reduced ejection fraction, and mid-range 41 to 49, and more than 50% called heart failure with preserved ejection fraction. And there is improving category, gray zone. It is improved ejection fraction. These are patient baseline is less than 40% or equal, and more than 10 points increase in the baseline of LV ejection fraction, and improving the symptom as well. What are the challenges that we face when we treating our patient with heart failure? As we see here, desire to do more. I want to improve their quality of life, improve outcomes, symptoms, simplify dosing, and achieve positive impact for them. And also without doing harm, and good safety profile, and preserving the kidney function, and minimal contraindication due to polypharmacy. There is, we will go deep for the new medications, but it's from diabetes to non-diabetes, and for treating heart failure, which is preserved or reduced ejection fraction. This family is called gliflozins. We will discuss about the old one is cangaflozin in Fucana. Dosage was 100 to 300, and the reduction in the HbA1c can occur less than 0.7%. And the SGLT2 inhibitor, it can given 2.7, and the consideration for the patient we can give in reducing BP and increase the risk of the lower limb amputation. So it is decreased from the market in the past years. And on the studies on it, it was program of Canvas. It can give us some idea about the good risk, reduce risk in death from the cardiovascular events, non-fatal myocardial MI, non-fatal stroke. The new family is Jardiance empagliflozins. There's 2 dosage, 10 and 25, and they reduce the HbA1c 0.6, and use in patient with previous stroke or MI or preserved ejection fraction. There is a study in PAREG outcome, reduce heart failure hospitalization and death from cardiovascular care. Also, there is dapagliflozins 5 and 10 mg, and they reduce the HbA1c less than 0.82, and it is consideration for the patient positive effect على LDL cholesterol or HDL cholesterol. And there is a study on it, declare TIMI, and reduce heart failure hospitalization and cardiovascular deaths. The new one is Celigrato erdagliflozin. Is a dosage, it will be 5 and 15, and they reduce the HbA1c 0.09. And there is consideration for the patient to strict EGFR restriction less than 60 milli per minute per 1.7 square. And the study on it is BERTS CV, estimated completion date by December 2019. SGLT2 inhibitors can cause glucosuria, and they can make for the heart failure decrease the symptom by decreasing BP, but can increase to eliminate ketone utilization. And for the fat cells, it increases the lipolysis and decrease the fat mass. On the pancreas, it increases glucagon, decreases insulin, and beta cell preservation. On the brain can also making as a compensatory increase in appetite. On the liver can decrease steatosis and increase hepatic glucose output and increase ketogenesis. What is the adverse effect from SGLT2 inhibitors? Ketoacidosis, hypoglycemia, genital mycotic infection, UTI, volume depletion, related adverse events like hypertension, syncope, dehydration. But on SGLT2 inhibitors, randomized controlled trials increase rates of volume depletion related adverse events. It range about 0.3 to 4.4% compared to placebo. Bone fractures Reason unknown, proposed mechanism, fall because from the volume depletion, maybe cancer for near gangrene, and lower limb amputation with canvas program trials, placebo, and renal safety can propose mechanism as osmotic diuresis and increase risk of hyperosmolarity and dehydration. As we see here again, for the SGLT2 inhibitors in patients with type 2 diabetes and renal impairment, canagliflozin can be given till 40 or 60 milli, but not recommended if the patient is between 30 to 45, as well as dapagliflozin, empagliflozin, and ertugliflozin. All are not recommended less than 30. For the trials they made on this family, as we discussed before, there is design for EMBAREG outcome trial 2016 describes the cardiovascular safety of empagliflozin in patients with type 2 diabetes at high risk for cardiovascular events, and it was designed as 1:1:1 fashion to either empagliflozin 10 and matching placebo, and it was on the total number 7,000 and on duration about 3 years. Another one trial is Canvas to evaluate canagliflozin compared to placebo, and it was on patient with type 2 diabetes, and it was on the arm of received 300 mg daily or 100 mg daily, and total number it was 10,000 patients on 188 weeks. And declared to me it was 2018 to assess cardiovascular safety of dapagliflozin in patients with type 2 diabetes mellitus, either established cardiovascular disease or multiple risk factors. It was also designed as dapagliflozin to placebo on total number 17,000 patient, duration about 4 years. And DAPA heart failure 2019 to evaluate dapagliflozin compared to placebo in patient with heart failure to reduce with reduced ejection fraction HFrEF patient, and it was on about 4.7 thousand patient and duration about 18 months. Inclusion criteria, as we see here in EMBAREG, it was age patient more than 18, hemoglobin A1C is more than 7, PMI less than 45, eGFR more than 30, established cardiovascular disease. For Canvas type 2 diabetes mellitus, more than 30 years patient, symptomatic atherosclerotic cardiovascular disease, hypertensive, systolic more than 140, and albuminuria, and HDL less than 38.7. For declared TMI, the inclusion criteria, it was patient more than 40 and HbA1c 6.5, more than 6.5, uncontrolled, eGFR more than 60, established cardiovascular disease or multiple cardiovascular risk factor. And for DAPA HF heart failure, it was for symptomatic heart failure patient, ejection fraction less than 40%, and there is pro-BNP more than 600, and patient with more hospitalization from heart failure last 12 months. DAPA HF is very important on HFrEF patients, so primary composite outcome, it was cardiovascular death to heart failure hospitalization and urgent heart failure visit. Comparing diabetic and the non-diabetic patient, as we see here, there is about 0.75 to placebo in diabetes, and in non-diabetic 0.73. So primary outcome for them, all of these for cardiovascular deaths and non-fatal MI stroke, but for DAPA heart failure for many hospitalization from heart failure. So our conclusion from these trials, as we see here, EMBAREG is a patient with type 2 diabetes mellitus at high risk of cardiovascular events who received empagliflozin compared to placebo had a lower rate for primary composite cardiovascular outcome of death, and from cause when study drug we added standard care. For Canvas patient with canagliflozin, they had a lower risk of cardiovascular events who received the placebo, but there was risk for some amputation, so it decreased from the market. Declared to me in patient with type 2 diabetes mellitus had a risk for atherosclerotic cardiovascular disease, and treatment of dapagliflozin didn't result from higher or lower rate of MACE than placebo. but they get a lower rate from cardiovascular disease and hospitalization from heart failure. DAPA-HF, it was among HFrEF patient, and there is good significant in lowering the hospitalization rate to the patient that received dapagliflozins. So current recommendation for our use SGLT2 inhibitor consensus recommendation 2016 guidelines indicate empagliflozin should be considered in patients with type 2 diabetes in order to prevent or delay the onset of heart failure or prolong life. 2019 expert consensus that canagliflozin and dapagliflozin should be considered in patients with type 2 diabetes, either established cardiovascular disease or at high risk cardiovascular disease, to prevent or delay the onset of and hospitalization from heart failure. At this stage, no specific recommendation for the use of SGLT2 inhibitors more than these established criteria. Again, this is our family and the trials in Bareg will Canvas will declare will Vertis in the next medicine. As we see here, clinical benefits from cardiorenal effects for SGLT2 inhibitors, many importance that can decrease the cardiovascular outcome and mortality in type 2 diabetes mellitus from England journal. There is some kidney outcome trials in patients with type 2 diabetes for the patient with empagliflozins, and Canvas declare and another trials. All of these recommend less than 13 not can be given. Cardiorenal protection mechanism for SGLT2 inhibitors, as we see here, it has to decrease glycemic toxicity for weight loss, for adiposity and inflammation, arterial stiffness, systolic blood pressure decreasing, and hematocrit and hemoglobin can increase, plasma volume decreases by natriuretic effect and natriuresis effect on the kidney. For example, we will discuss one case, a 68-year-old woman at high risk of cardiovascular event and heart failure. She has type 2 diabetes mellitus, HbA1c uncontrolled 7.7%, hypertensive, hyperlipidemic, had PCI, atherosclerotic cardiovascular disease before, and with angina. Currently, she is asymptomatic and mild ankle edema, BMI obese 30, and blood pressure is high, 145/85. Creatinine level is 97 and eGFR 55, and there is microalbuminuria. Current medication is aspirin 100, atorvastatin 40, and metformin 1000 BD, glycoside 60 mg BD, enalapril 10 mg BD, and cardivolol 6.25 mg BD. Comes for regular follow-up, and what can we do for further reduce her risk for cardiovascular disease? I want to protect her heart more, so we will add for her impact of glycemic control. Of the intensive glycemic control does not appear to reduce the risk of all-cause mortality, but as from the study, it will reduce the risk of non-fatal myocardial infarction. So it is cardioprotective, and the patient's clinical functional status, it will improve self-management capacity, social support, medication, and hypoglycemic risk and treatment burden. So we will add from here, as per guidelines 22 expert 2020 consensus decision, that pathway of novel therapy for cardiovascular risk reduction in type 2 diabetes mellitus. We will give for this patient as recommended SGLT2 inhibitors or GLP-1 receptor agonists to prove that there is cardiovascular benefit, and depending on patient-specific factors and comorbidities. And from also diabetic care guidelines, as we see here, all the patient indicated for high risk or established cardiovascular disease, there is CKD or heart failure symptom. This patient with should start from the step 1 is SGLT2 inhibitor with proven benefit in their population with cardiovascular protection. So option to reduce cardiovascular risk in this patient, we will optimize diabetic mellitus glycemic control and describe for her glucose lowering medication by evidence-based cardiovascular benefit and mortality benefit, and optimize the cardiovascular risk and it targeted HbA1c less than 7% and BMI less than 25, BP less than 130/80. So we will switch to medication with cardiovascular and renal and mortality benefit irrespective to HbA1c. We will recommend SGLT2 inhibitor for this patient and recommend as well lifestyle modification option. And this also the guidelines from European 2016 guidelines cardiovascular diseases prevention, and for the 2019 guideline primary prevention in cardiovascular diseases. As we see here, we can prescribe for the patient diet, physical activity, body weight control, blood pressure control, and lipid and diabetes control, and also as well tobacco management. Another case is 42 years old lady, diabetes mellitus, recently diagnosed with stage C, HFrEF patient, non-ischemic cardiomyopathy, and LV ejection fraction is reduced to 30%, and normal coronary arteries by angio. And PP is 135/75, BMI 28, current medication interest to 100 BD, and carvedilol 25 BD, spironolactone 25 once daily. Cardiovascular examination was unremarkable. HbA1c 6%, creat 88, eGFR 77. And what is the option for this patient to get benefit to reduce her risk for future poor outcome on her heart, as it is already reduced ejection fraction? So the treatment algorithm from the guideline directed medication therapy to 2021 update to 2017 ACC expert consensus decision pathway for optimization heart failure treatment answer that 10 pivotal issues about heart failure with reduced ejection fraction. As a patient with criteria of HFrEF patient less than 40% with or without diabetes, NIHA class 2 to 4 heart failure, administration in conjugation with a background of controlled diabetes, and for heart failure optimization medication, we will add, as we see here in the red square, for the patient with meeting eGFR, we will add for them SGLT2 inhibitor after administration of aldosterone antagonist, and diuresis for symptom control, hydralazine in some patient, and ibuprofen if there is sinus tachycardia. So the 4 caterpillars for us in HFrEF patient is ACE inhibitor, ARNI, beta blocker, mineralocorticoid antagonist, and the cornerstone now is SGLT2 inhibitors, as we see here in 2021 guidelines, treatment of acute and chronic heart failure. Class 1 indication is dapagliflozin or empagliflozin for the patient with HFrEF to reduce the risk of heart failure, hospitalization, and deaths. And also class 1 indication for SGLT2 inhibitor, cangaflozin, dapagliflozin, empagliflozin, erdagliflozin, and sotagliflozin for recommended to the patient with type 2 diabetes mellitus to decrease the risk of cardiovascular outcome and reduce the hospitalization from heart failure and major CV events and end-stage renal dysfunction cardiovascular deaths. And this is also some graphs from New Journal of England. As we see here, decrease in cardiovascular deaths about 18% and heart failure hospitalization about 30%. Reduce the risk of worsening from the heart failure, and finding the patient with diabetes were similar to those in patients without diabetes. So as we see here, this is the important SGLT2 trials. As we see before, DAPA-HF, Emperor reduced NEJM 2022, Solicit NEJM 2021 on the heart failure with type 2 diabetes mellitus. There is option to further reduce the risk factors for heart failure according to the good evidence-based medication. We will add for this patient SGLT2 inhibitor, lifestyle modification, and the cardiac rehabilitation for heart failure. There is an adverse effect from SGLT2 inhibitors. Again, we can consider some patients with genital urinary infection from dehydration, hypoglycemia, diabetic ketoacidosis, renal injury, and some volume depletion and lower limb amputation with Invokana. Safety, as we said, it is safe for the patient for cardiovascular outcome and renal impairment patient, and prescribing for SGLT2 inhibitors from the guidelines is a stepwise approach to prescribe them by cardiologist after selection of the drug and initiation for the safety for the patient. And there is illustration for unfavorable cardiometabolic renal effect and sodium SGLT2 inhibitors. From the benefits, it will give the positive way for this patient favorable effect to prevent the instance and treat the established heart failure reduction into major risk factors, and the cardiovascular outcome, reduction in blood pressure, preserve renal function, improve in glycemic control. Conclusion. SGLT2 inhibitors have a change to management in the patient with diabetes and cardiovascular diseases or heart failure. Now, SGLT2 inhibitors have been shown to be beneficial also in heart failure patients without diabetes and potentially in those with chronic kidney disease. It's important to be familiar with the benefit and prescribing detail of this important class of medications so they can be utilized to improve the clinical outcome of the patient. And thank you. I finished my lecture and I'm glad from the attendees and if there is any question, okay, or at the end of the session, as you see.
Well, thank you, Dr. Shaima, for your nice presentation. Dr. Molina also, he joined the team. If you can introduce him, and you can keep the answer, question and answer at the end, will be better.
Okay.
Okay. Good morning, everybody, from Chile, Manchester. Shall I start?
Hello, Dr. Molinat. Good morning. Sorry to disturb you so early in the morning.
It's okay.
You're good? So I would like to introduce Dr. Molinat Banerjee, who is a consultant physician and clinical head in diabetes, endocrinology, weight management, and general medicine. So Dr. Molinat, just trying, but it is so small, the writing. Okay, at the divisional research and the divisional research lead for acute adult division at Bolton NHS Foundation Trust. So Dr. Molinat has received honorary clinical, he's an honorary clinical lecturer in country for endocrinology and diabetes, research group, University of Manchester, United Kingdom. He also has received a PhD from Manchester University following a successful grant receipt from the British Heart Foundation. Dr. Molinat has led quality improvement projects and published peer-reviewed articles in various journals of diabetes and endocrinology. And Dr. Molinat is an associated editor of the British Journal of Diabetes and clinical champion of diabetes in the UK. Dr. Molinat, you can share your slides now. The floor is yours.
Okay. All right. Thank you very much for the kind
We
introduction.
cannot hear you. Cannot hear
And-
you.
Oh,
Just check your mic, doctor.
yeah, my microphone's working. Just bear with me a minute.
Cannot hear you.
Okay.
أنا مبين ما شايفني. We still cannot hear you.
Okay, just bear with me a minute. Let me see. Mhm.
Yeah.
Just bear with me a minute.
Can hear.
Trying to find out.
Oh. Okay, doctor.
Can you hear me now?
Yes.
Okay, that's fine. Yeah. Okay, sorry about that.
No problem.
Okay. Can you see my screen now?
Yes.
Okay. Good morning, everybody. It's quite chilly up in Manchester. Obviously, it's not that way down in Bahrain. Thank you very much for inviting me for this IMDO conference once again. I'm thrilled and delighted to attend it. I've picked up a very topical point, slightly on the basic science end of polyincretin therapy and the impact on the management of diabetes and endocrinology. Thank you very much for the very kind introduction. And these are my disclosures regarding my education and travel grants and my speaker fee from various companies. So if we can go to the basics, I know we have been using the GLP-1 analogs for a very long time now, but I was just wondering if we could sort of revise on the point regarding what the incretins are and what exactly we mean by the incretin therapies. So incretins are natural glucoregulatory peptides, and we have got two that we have identified till now. One is the glucagon-like peptide, is GLP-1. The GIP is the glucose-dependent insulinotropic peptide, but it used to be called gastric inhibitory peptide as well because its first role was found out as that it reduced the gastric emptying. So both these hormones increases glucose-dependent insulin release, and also it reduces the gastric emptying and slows down the overall bowel movement, and hence it reduces the peak of the glucose. Now, the main reason why they are called the incretin is when Nock published in Diabetology in 1986, is a lovely graph which showed that when glucose load was given of 50 grams in 400 mils of water, it produced a peak of glucose and it came down. These were in healthy volunteers. But the insulin response was quite different when they actually gave the IV glucose, and the oral glucose produced a much bigger insulin response than the IV glucose. And the point was that there was something happening in the gut, and the gut was producing some hormones which led to an increased insulin response. And that difference in the response, which is called as the incretin effect. So nowadays we are talking about the incretin system because our knowledge is expanding every day. We know about two definite incretin hormones at the moment, but the effect of the incretin system is a bit widespread. It's working on the pancreas by improving the insulin response. It's working on the gut by slowing the gut response. It works on the brain, on the satiety center, and it makes us feel a bit full. It works on the liver, and it reduces the amount of liver fat content. It works on the adipocytes and looks at how the adipocytes handle triglycerides and thereby also the adipocyte maturation. And it changes the overall body's sensitivity or resistance towards insulin action. The most important thing, and one of the things which is closest to my heart, is the work on the endothelium or the vascular function. And that has been known to contribute towards the cardiovascular benefit of the incretin hormones. Now, the reason why we are talking about incretin system nowadays is that we know about two. Our knowledge is limited, as I mentioned before. We may be coming out with more incretin hormones, which we'll be able to identify in the future. We don't know. But what we are trying to find out is what are the areas that all these hormones actually work for our benefit of the overall system. Now, this was a very nice slide produced by the Endocrine Society in the Endocrine Reviews a few years ago, about good 5 years ago. And they included glucagon in it as well. Now, glucagon, we are all concerned, is that it goes up in type 2 diabetes. But what we can see is that in this picture, the glucagon is marked in red, GLP-1 in blue, and GIP in green. And if you can see here, it works in brain along with GLP-1 and some amount of GIP. It works on the brown adipose tissue, but in the heart, it's mainly GLP-1 and GIP, not much of glucagon. In liver, obviously, we know that it increases the glucose production by the new glucogenesis and glycogenolysis. In the stomach, all three of them work. In intestine, it's mainly GLP-1. In the bones, it's GIP which works. In the adipose tissue is glucagon and GIP. And intestine, the lipoprotein secretion is mainly mediated by GLP-1. So we can see that the glucagon and GLP-1 and GIP, they work in a very close unison in different tissues of the body to improve their function or alter their overall function. And hence, glucagon is not an incretin hormone yet, but it is still used in combination, and we'll come to that in a minute. So GLP-1 was the first incretin hormone that was identified and has been used extensively since 2006, 2007 onwards. So it's a 30 amino acid peptide. It's cleaved from the proglucagon in the L cells of the GI tract and neurons in the hindbrain and the hypothalamus, and it's secreted in response to the meal ingestion. So once we have the diet, the food goes through the small gut, and the L cells in the proximal, in the jejunum and the ileum, they produce these hormones. They go and work on the pancreas and also in the liver and produces its effect. Now, what we know is that the GLP-1, once it's secreted in the bloodstream, it has a very, very short half-life. In healthy volunteers, in this side of the slide, if you can see, the half-life is somewhere around half a minute to 2 minutes once it's secreted, and once it's given as an intravenous bolus. It is degenerated or degraded by the DPP-4 enzyme system. Now, that is the reason why the DPP-4 inhibitors came up, so that we can actually prolong the native GLP-1 that we are already producing. Now, the DPP-4 activity is almost similar in the healthy individuals and type 2 diabetes patients, and hence work on that DPP-4 inhibitor would actually be beneficial for type 2 diabetes. And we have seen, and we have been using it for last good 15 years or so with the DPP-4 inhibitors. But what we know is that they are not as effective as the GLP-1 analogs. Shall we go back to a bit of a history of the development of GLP analogs? In 1906, that was the first time that we had the duodenal extracts showed that duodenal extracts were shown to stimulate the internal pancreatic secretions. In 1964, the first time the incretin effect was described. 1983, GLP-1 encoding was done. 87, GLP-1 was shown to trigger insulin release in vitro. 87, it exhibits incretin activity in the humans. 1992, exendin 4 was identified in Gila monster's saliva. Now, this was one of the big groundbreaking points, because we know that GLP-1 doesn't work for more than 2 minutes, but exendin 4 was found that is actually longer acting in humans. In 1992, the GLP-1 genome was coded, and 1993 was first time it showed that GLP-1 can normalize blood glucose in type 2 diabetes. 93 GLP-1 inactivation was shown to be caused by DPP-4. 2005, it was the first injectable GLP-1 receptor agonist to be licensed in type 2 diabetes. Now, in 2019, we had the first oral GLP-1 agonist for type 2 diabetes from Novo, and further things have developed since then. Now, when we talk about the GLP-1 receptor agonists in clinical use, we can divide them between the human GLP-1 receptor-based therapies, and we've got the dulaglutide, liraglutide, and semaglutide in that group. While in the exendin-based therapies, we've got exenatide, which was the first one, which can be given daily or twice daily, and weekly one, and also lixisenatide, which can be given once a day. Now, the question is that we have talked about a lot about GLP-1. We already know about GLP-1. Now, is there a GIP agonist? We have not heard about that very much. Now, GIP 3 to 30 amide peptide is a short-acting GIP agonist, which obviously we can't use clinically. And the LY3537021 is a long-acting GIP agonist, which is now being worked on, and hopefully we will be seeing it in its form or in a modified version in the future. But we still don't know how much the GIP agonist itself will be beneficial or not. Let us wait for the clinical trials to come out. Now, the main part of my question was, of my topic of talk was polyincretin therapy. Now, polyincretin is where more than one incretin receptor is activated. Now, it is not where we are mixing two agents or two or more agents, but it is where we are getting a single drug to work by acting as an agonist of two or more incretin hormones. Now, we can say that the DPP-4 inhibitors, they are polyincretin agent because they are inhibiting the degradation of both GLP-1 and the GIP. Now, when we are talking about that, it's a single molecule. It's working on a system, the DPP-4 inhibitor system, DPP-4 system, and inhibiting it. So it's increasing the GLP-1 and GIP levels in the blood, and they are giving us some benefit as well. Can we consider bariatric surgery as a polyincretin therapy as well? Now, the reason why I've put that one in, it's slightly controversial. I've put it down as a polyincretin-inducing procedure because what we know is that following bariatric surgery is an absolute supraphysiological surge of GLP-1, GIP, and glucagon, and they are thought to be having a positive effect on the weight loss, glucose sensitivity. And what we know is that type 2 diabetes in about 75 to 80% of patients, it just disappears altogether, which is a fantastic response. But the jury is still out whether we can call it as a polyincretin procedure or not. Now, when we are talking about poly, I've deliberately gone down the route to mention about the triagonist area. So we are talking about a triagonist as a GLP-1, glucagon, and GIP all working together. Now, going into the molecular chemistry of this, we can talk about a balanced fusion structure of having all these three peptides or together, and these individual peptides are used to provide recognition at all receptors. So we can combine all of them together. Now, this is going to be a very complex procedure because the peptides have different alpha structure, the beta structure, and if we're trying to combine all of them, they may not work together. The option is to have a balanced hybrid peptide, which is a sequence hybridized molecule of similar size to the native peptides, but they have equipotent activities at all receptors. Now, when we're trying to produce balanced hybrid peptide, we may not be able to produce the balance very well, and we actually tend to produce an unbalanced hybrid peptide, which has a sequence intermixed with the molecule as original molecules, but they don't have the equipotent property for all the three, GLP-1, GIP, and glucagon. Now, that we really don't want an unbalanced hybrid peptide, but we do produce them, and we do have an imbalance between the activities of GIP and GLP-1, and sometimes with glucagon. Now, these are the sort of downsides in the pipeline while we are producing such complex molecules. Now, we've been talking about glucagon, and I've shown that the glucagon works in different areas. Now, why do we go for glucagon agonism? when we know that glucagon is really bad in patients with type 2 diabetes. Now, if we go back to what we've learned from bariatric surgery over the last 15 to 20 years, is that there is a post-surgical rise in the level of plasma glucagon. Now, but that does not lead to rise in the blood glucose because the diabetes goes away. So there is a bit of there was a gap here, isn't it? Now, when we did bariatric surgery in animals whose pancreas was removed, it was found that the glucagon rise still happens, but it happens in line with the GLP-1 rise. And it was thought that it's the intestinal L cells which is producing this glucagon. Now, what we also need to remember that in intact individuals where there's no pancreas removed, the insulin response is restored, and this balances the effect on the liver glycogen. When we are talking about type 2 diabetes, we're talking about the insulin being less available and glucagon being high, and that affects the increase in the gluconeogenesis and glycogenolysis, which increases the blood glucose formation and release. Now, in post-surgery, in patients with post-bariatric surgery, because the insulin response is now better, that effect actually is reversed. Now, this is something very important because that is why we are actually using the glucagon agonism. Now, when I showed the previous slide on the effect of the GIP, GLP-1 and the glucagon, talked about the brain as well as the gut and the liver. And what we know is that there is a beneficial effect on energy expenditure by glucagon agonism in intact individuals. Now, if I can summarize that, is that if we have glucagon and insulin deficiency together, which we see in type 2 diabetes, that is detrimental to overall weight loss and obviously insulin sensitivity. But if you have high glucagon, but restored insulin secretion in post-bariatric surgery, we have found that to be beneficial for that individual. Hence, excess glucagon is actually good. Now, what I also need to inform there is that in type 2 diabetes and especially longer term patients with type 2 diabetes more than 5 to 10 years, we have seen that the glucagon response can be impaired as well, which actually further complicates the situation in these patients. Now, I've talked about 3 different molecules here, and what are we looking for? When we look at the Venn diagram on the right, we can see that the GLP-1 analog and the GIP analog combination, and that is something that is already in the market, which is the tirzepatide. The GLP-1 analog and the glucagon combination is the survodutide in the pipeline. And GLP-1, GIP, and glucagon analog, the triincretin one, that is what we call is the retatrutide, which is already in the pipeline as well. There are quite a few other molecules. I have not gone into them in detail because they are still not around and they are still in development in a very, very early stage. Now, what I'll do is I'll talk about tirzepatide a bit more detail. This is something we currently have in the pipeline, currently have in our armamentarium, and compare that with the semaglutide. If I could show that the main difference is that the basic GLP-1 chain is still remaining there. In semaglutide, that has been modified with this extra chain that's added to the amide molecule there. But while in tirzepatide, that chain is not there, but this C20 fatty diacide chain is there, which changes both the specificity of the molecule as well as the half-life of the molecule. Now, how does the tirzepatide work? And it is named as the twin cretin because it's working on 2 systems, the GLP-1 and the GIP. Now, it works on the GIP receptors and stimulates the cyclic AMP generation. Now, cyclic AMP generation leads to increase in the glucose-mediated insulin secretion. At the GLP receptor, it works on the cyclic AMP generation, but it also works on the beta-arrestin recruitment. Now, beta-arrestin is a very, very important molecular system which stimulates beta cell proliferation and also prevents the death or apoptosis of the beta cells. And hence what we see is that the new beta cells are growing And the ones that are already there, they are actually not dying. So we are increasing the beta cell mass, which we know is as the type 2 diabetes progresses, we get a reduction of the beta cell mass. Now, there are a lot of trials and a lot of data there, but this was a meta-analysis published last year, which compared tirzepatide with semaglutide. And what we can see is that tirzepatide has a definite improvement in HbA1c, and it's a dose dependent. So 5, 10, and 15 milligrams have 3 different dose improvement with the weight, and it's definitely beneficial. When we look at the weight point of view, the benefit is similar, but slightly better than what we see with the HbA1c. But both of them are significantly improved on both HbA1c and weight. Now, obviously, since 2015 or so, 2010 or so, the cardiovascular safety has become a paramount thing for patients with type 2 diabetes. What we see is all the molecules now coming out into the market for use with type 2 diabetes have to prove that at least they are not cardiovascularly impairing the function. The cardiovascular outcome trial for tirzepatide is still awaited. We are expecting in 2025 it to be published, the SURPASS CVOT trial. And what we know is just there, if I can sort of digress slightly, is that epaglenetide is a new GLP-1, which has a dose titration weekly, but it can be given once the stable dose is achieved, it can be given monthly. So that is a molecule, but it's a pure GLP-1 analog, which is important to remember. Right, let's go back to tirzepatide again. So we don't have the cardiovascular outcome trial yet, but what this showed is published in Nature in 2022. This is the pooled cardiovascular outcome trial of all the trials that we currently have, but the maximum that we have now is up to 120 weeks, which is the short of 2 years trial. And there's only one, the SURPASS 4, which had that. And what we can see is that it definitely has a positive effect on the cardiovascular outcome in patients who are put on tirzepatide. So there is some confidence that it's actually not causing any extra harm, but obviously we have the patients booked in here between 30 and 120 weeks, 108 weeks, and we still need the cardiovascular outcome trial to come out. But we can be confident that if we are starting them on tirzepatide, hopefully we are not seeing any adverse outcome on the cardiovascular front for them. This was an article on meta-analysis published where they looked at specifically on the weight part of the tirzepatide, and they showed that the 5 milligram dose caused a weight loss of 7.5 kilograms. 10 milligram caused about 10.5 kilo weight loss as the pooled analysis, and 15 milligrams caused a 10.9, almost 11 kilo weight loss. And average combining all the 3 doses, there was almost a 10 kilo weight loss, which I think is quite phenomenal. We are looking at some of the bariatric surgery procedures like gastric banding, which actually fares less than this. Hence, tirzepatide's there, which is causing significant weight loss. But the big question which comes out is the cost of it, because it's quite expensive when compared to, at least in the UK, it's more expensive than the GLP-1s that we are seeing at the moment. Now, the current license for tirzepatide, as mentioned by FDA, is type 2 diabetes as well as obesity. It's a massive dose range that's available. And the indication is either BMI more than 30 kg per meter square without any associated obesity-related complication, or BMI more than 27 kg per meter square with associated complications like type 2 diabetes or any osteoarthritis or any other complication of obesity. Let's move to a slightly different molecule, which is the survodutide, and it is a twin cretin, which is a GLP-1 and a glucagon analog. It's being developed by Boehringer Ingelheim and Zealand Pharma, and currently is in phase 3 clinical trial for the type 2 diabetes, obesity, and NASH. And this is very important regarding the NASH, the non-alcoholic steatohepatitis group. And survodutide has been put up by FDA on a fast track development looking at the NASH because it has some significant improvement on the NASH outcomes. I'm not going into NASH here because we're looking mainly for the diabetes and obesity angle. And what we can see is that if I can bring it down, that this blue line is the semaglutide arm of the trial. This was published only last year. And we can see that the survodutide doses actually fared similar or slightly better than semaglutide. So there is a bit of a benefit there. And though the weight loss arm is quite a bit fuzzy there, but we are talking about a maximum of 18-week data in this study. This is a phase 3 trial, early phase 3 trial. And so we need a much longer study to look at the survodutide. But these early outcomes are really, really important, that it actually shows up the benefit of this drug. And hopefully we will be having it in clinical use soon. Let's come to the retatrutide. Some of you may know it as the LY3437943 molecule if you have been part of the clinical trial. And this is the first triagonist, which actually is an agonist for GLP-1, GIP, and the glucagon. There are 4 dose ranges here, 2, 4, 8, and 12. It's a once weekly preparation developed by Lilly and currently in phase 2 clinical trials. And these graphs are from the phase 2 clinical trials as well, published only in last year. And it shows a definite improvement in weight. And we're talking about 24% weight loss, which is quite significant. We are in the realm of comparing it with bariatric surgery. The right panel shows the use of retatrutide and improvement in their glycemic control in their various dose ranges. Now, again, overall, very, very early, we're talking about phase 2 trials here. We've got massive work, but it shows that the triagonists actually work. In summary, if I can say that we're talking about the 3 hormone systems, and incretin therapy in the future could be split between monotherapy, twin incretin therapy, and polyincretin therapy. Now, what I want to focus here is that why are we going for a polyincretin therapy? It's because in our body, the GLP-1 or GIP or glucagon, they don't work in isolation. It's an overall body system, the biology, where all these molecules work together. And if we can find the right proportion in which they can work, it actually would be beneficial, which we are seeing now. Now, obviously, science is progressing. We are learning something new every day. And hopefully, we will be getting more polyincretin therapies. And not only 3, we may be getting the newer incretins as well, which are being brought up in the science as well as in the clinical use very soon. And that's the end of my talk. Thank you very much.
Thank you, Dr. Molinat, for the informative talk presentation. Thank you so much, and getting you up so early and in a chilly morning in Manchester. Thank you so much. So far, we have no questions now. Maybe later on at the end of the session, we might get some questions.
Okay, no problem.
Would you like to introduce the next speaker?
Absolutely, no problem at all. Thank you.
Yeah, that's Dr. Ahmad.
Okay.
Yeah.
Yes, it is my absolute pleasure to welcome Dr. Ahmed Salahuddin. He's an ENT specialist at Dr. Abdullah Kamal Medical Center and a former ENT specialist at the Noor Specialist Hospital, and also at the Al Gharib Medical Center and Bahrain Sleep Lab, and former ENT specialist and ENT unit coordinator at Alexandria New Medical Center. Dr. Salahuddin, please feel free to start your talk when you're ready.
Yes, doctor, they will start. It's a recorded presentation.
Okay.
Thank you so much.
Thank you.
Bismillah ar-Rahman ar-Rahim. Good day for everyone. My name is Dr. Ahmed Salahuddin Sherbini, ENT specialist in Dr. Abdullah Kamal Medical Center. Honored to be a regular part of the IMDO family every year. My topic of my lecture this year is about sleep apnea in diabetic patients. We start to say that sleep is not just the absence of wakefulness. It is rather than active, complex, highly regulated, involve different area in the brain, essential for life, and simply we all do it. So we sleep for 8 hours per day, 56 hours per week, 224 hours per month, and 2,688 hours per year. The sleep is composed of the repeated sleep cycles. Each sleep cycle consists of 4 stages. Stage 1, there is light transitional sleep, and there is drowsiness, and the sleep begins. Then we pass to stage 2, in which more chemicals produces from the brain block our senses and make us difficult to be waken up. Then we pass to more deep stage, stage 3, where growth hormone released. Most of sleep occurs in this stage. It occurs in the first third of the night. Then we pass to stage 4, or what we called rapid eye movement sleep, or REM sleep, in which we revitalize our memory and the brain activity is very high and dreaming occurs. Each sleep cycle consists of from 90 to 120 minutes. Each REM, non-REM coupled equal to 1 cycle. We go through 4-5 cycles for each 7 to 8 hours sleep. Most of the REM cycles gets longer and closer as the sleep length gets longer. Most of the non-REM deep sleep occurs early. First REM period is the shortest one. This is the examples of the different brain waves activity that occurs during the whole night sleep and how it is different from each other throughout the stages of the sleep. These brain waves called alpha, beta, theta, and delta, and that's how they look like. In the alert wakefulness state, the beta waves predominate. In the quiet wakefulness, alpha wave predominates. In the stage 1 sleep, there is low voltage and spindles. And in the stage 2 and the stage 3 sleep, the theta waves predominate. In the stage 4, there is our slow wave sleep or delta waves. And in the rapid eye movement sleep, beta wave predominate. Then we'll talk about snoring and sleep apnea. So what is sleep apnea? It's momentary cessation of breathing or a regular breathing pattern while asleep. Apnea is a complete interruption of respiratory airflow lasting more than 10 seconds. Hypopnea is the decreased respiratory airflow. Apnea is either central, obstructive, or mixed. Central apnea, where there is no effort for breath is made. Obstructive apnea, there is ventilatory effort, but no airflow because the upper airway is closed or collapsed. Mixed apnea, this is initially no ventilatory effort is made, but an obstructive pattern occurs when the effort is restored. What occurred in the pathophysiology? There will be snoring, tissue laxity, and redundant mucosa. There will be anatomic abnormalities, decreased muscular tone, especially with REM sleep, and airway collapse. This is the example were the sites of obstruction for the airway, and usually these sites tend to propagate from up to down. Also there will be desaturation, arousal to restore the airway, sleep fragmentation, lead to hypersomnolence, which is recurrent episodes of excessive daytime sleepiness or prolonged nighttime sleep. Desaturation and compensatory polycythemia, hypercapnia with pulmonary hypertension, systemic hypertension, or arrhythmias. So sleep disordered breathing, which is either obstructive sleep apnea, upper airway resistance syndrome, or primary snoring. The obstructive sleep apnea results in oxygen desaturation. Upper airway resistance syndrome, it's similar to obstructive sleep apnea, but no desaturation. Primary snoring is regular snoring without changes in the sleep architecture or alveolar ventilation or oxygenation. So why we seek a medical advice? Here I want to highlight that many of obstructive sleep apnea patients may not come directly to the ENT clinic asking for help. They are either denying, underestimating the problem, or even feel embarrassed. But many of them may go for my seniors and colleagues in different specialties with different complaints that may be related to their long history of sleeping problem and deprivations. That's why for helping these patients, we have to involve sleep medicine in our management plan. Then we will go to talk about metabolism during sleep. The whole body energy expenditure drops by 15 to 30% during sleep. Lowest energy expenditure during slow wave sleep. Slightly higher during the rapid eye movement sleep. Plasma glucose level progressively increased during sleep. Highest level in the early morning. Glucose utilization highest during the wakeful state, lowest during the non-REM sleep, and intermediate during rapid eye movement sleep. Glucose metabolism during sleep. In the first half of the sleep, increased glucose level, reduction in the cerebral metabolism, decreased in the muscle tone, increase in the clearance of insulin and growth hormone. In the second half of the sleep, improved glucose metabolism in the REM sleep and awake state, and increase in the body activity. Here to highlight the hormones that controlling the sense of satiety and hunger. Leptin, which is appetite suppressant, in obese and patients with obstructive sleep apnea, independently, they have high leptin due to leptin resistance rather than result of leptin deficiency. Sleep deprivation disorders and disorders of sleep cause decrease in the leptin, making you feel more hunger. Treatment of obstructive sleep apnea with a CPAP decrease the leptin level and the ghrelin level. Then ghrelin, which is appetite stimulant, ghrelin level increased after weight loss. Ghrelin level higher in obstructive sleep apnea patients. Treatment of obstructive sleep apnea may reduce ghrelin levels, leading to decreased appetite. So, patient with sleep deprivation, prolonged wakefulness, high-fat diet. In the sleep, during the sleep time, he is fasting. So in the muscles, there will be oxidative metabolism, increased oxidative metabolism, increase in the lipid catabolism, and the leptin secretion. In the liver, there will increase in gluconeogenesis, glycogenolysis, mitochondrial biogenesis, and in pancreas, increase in glucagon secretion. During the wake and feeding stage, in the muscle, there will be increase in the fatty acid uptake and the glycolytic metabolism. In the fat, there will be increase in lipogenesis. In the liver, there will be increase in glycogen synthesis, decrease in cholesterol synthesis, increase in bile synthesis, and in pancreas, there will be increase in insulin secretion. So, short sleep duration or sleep fragmentation or obstructive sleep apnea and hypoxia will lead to either of three pathways that will end in increased incidence of hyperglycemia and type 2 diabetes. It will either lead to decreased leptin and increased ghrelin, and by this way increase the appetite, with many managed change in the energy expenditure that will lead to obesity and increase insulin resistance. By this way, they will end in hyperglycemia and type 2 diabetes. Or they will increase the sympathetic activity, alter the rhythm of cortisol and growth hormone secretions, increase in inflammatory markers that will end in either increase insulin resistance and decrease beta cell functions that will end in hyperglycemia and type 2 diabetes. Or either it will decrease the brain glucose utilization that will end in type 2 diabetes. Always, the obesity is a constant risk factor for obstructive sleep apnea. There are many comorbidities associated with obstructive sleep apnea. Diabetes is a constant one, around 50%. Also obesity, 40%. Chronic or congestive heart failure, depression, stroke, hypertension, with variety of percentage or association with obstructive sleep apnea. Always we have to break this vicious circle between obesity that will lead to increased fat deposition in the upper airway lumen and upper airway muscle, converting the upper airway shape to oval one, that will lead to obstructive sleep apnea, that will lead to decreased physical activity, increased insulin resistance, and increased ghrelin level that will lead to obesity, and so on. And obesity for sure is a constant risk factor for developing of type 2 diabetes. So sleep restriction and appetite control. In acute sleep deprivation, there will be decreased leptin level, so decreased satiety, and increased ghrelin level, and increased physiological hunger. In habitual short sleep duration, there will be decreased leptin level and increased ghrelin level. Sleep restriction and appetite. If in sleep restricted for 2 nights, only 4 hours per night, followed by 2 nights of sleep compensation, reaching to 10 hours per night, while receiving continuous glucose infusion, that will lead to reduction in leptin level by 18%, with significant predictor of magnitude of hunger. Increase the ghrelin level to 28%, that would lead to increased hunger and appetite rating. Increased preference for carbohydrate foods, high carbohydrate food, and salty foods. We always say that diabetes and sleep are poor bedfellows. Prevalence of sleep disorder in diabetes. Sleep disorder present in 50 to 70% of diabetic patients, either in obstructive sleep apnea, insomnia, poor sleep quality, restless leg syndrome, and excessive daytime sleepiness. Obstructive sleep apnea and diabetes. Obstructive sleep apnea is an independent risk factor for development of type 2 diabetes. 15 to 30% of patients with obstructive sleep apnea have type 2 diabetes. Increase in the severity of obstructive sleep apnea lead to increased type 2 diabetes incidence and poor glycemic control. Sleep Health Heart Study, large prospective cohort study, revealed that obstructive sleep apnea severity was associated with increased insulin resistance, and nocturnal hypoxemia was independently associated with glucose intolerance. There are also what's known as syndrome Z, which is metabolic syndrome with obesity, insulin resistance, hypertension, and dyslipidemia, plus obstructive sleep apnea. 5 to 9-fold increased in risk of metabolic syndrome in adults with obstructive sleep apnea. Continuous positive airway pressure therapy in obstructive sleep apnea patient improve glucose control, clinical significant improvement in glycemic control, amelioration or of evening fasting glucose metabolism, reduction in the down phenomenon. Impact of restless leg syndrome, decrease sleep quality, drug consumption at night, impaired daytime activity and cognitive function, the depressive and anxious symptoms, risk factor for hypertension and cardiovascular diseases. 21% of adults with diabetes have restless leg syndrome, fourfold the risk of development of restless leg syndrome in diabetic patients in comparison to general population. Association between napping, excessive daytime sleepiness, and metabolic syndrome with type 2 diabetes. Excessive daytime sleepiness increases risk of diabetes by 56%. Long daytime nap, more than 60 minutes per day, increase the risk of diabetes by 46%. Long time nap associated with risk of metabolic syndrome. So historically speaking, the first one who described the picture of snoring was Charles Dickens. In a papers published in 1837, he called the Pickwick Club. He described a boy named Joe who's even have high snore sounds even while awake and frequently fall asleep while standing. There are 4 simple steps for diagnosis and management of the problem. Physical examination, questionnaire, then we go for sleep study, either sleep study or sleep endoscopy, then we go for the treatment or the management. Simply we ask the patient to open up his mouth, and we notice the size of the tongue base, the length of the uvula, the size of the tonsils, and how they can affect the patency of the upper airway and the size of the lumen of the upper airway. This is what's called Malapathy score. Here we can easily notice the difference between class A, which we see all the lumen of the upper airway, ending in class 4, while we totally nearly see nothing because of the huge base of the tongue that nearly obstructing the whole upper airway. And this is a constant risk factor for developing obstructive sleep apnea, either like this picture, the huge tongue, or low redundant soft palate, or big kissing tonsils, especially in children. Also, there are what's called retrognathia, which is a type of malocclusion which refer to abnormal posterior positioning of the maxilla or mandible, particularly the mandible, relative to the facial skeleton and soft tissue. Then we go for what called polysomnography or sleep study, which is the single most important lab techniques used for diagnosis and treatment of sleep disorders. The technique of recording, analyzing, and interpreting multiple simultaneous physiological parameters during sleep. Indication: excessive daytime sleepiness, obstructive sleep apnea, breathing difficulties during sleep, and poor sleep quality or insomnia, to exclude other sleep disorders. We start by asking the patient simple questions regarding what is the opportunity for dozing off during the daytime. How often can he feel sleepy during the daytime in certain situation, like reading a book or watching TV, attending meeting or lecture, driving a car for a highway traveling distance, lying down after afternoon, driving a car in traffic time. Then we calculate how often he feel sleepy since dozing off during the daytime. Then either no chance or minimal or moderate or high chance. This is called Epworth score. Then we get a total calculation here. Then we go to another type of questionnaire in which we ask him about the symptoms he feels or his accompanying, noticing him. If there is a loud snoring, frequent wake-up, gasping during night, low concentration, poor work performance, his memory start to be affected, always sense of tiredness, he has sexual dysfunction, reflux disease, any other comorbidities like high blood pressure, diabetes, lung disease, depression, whatsoever. Then we put all the data we took from the patient, his weight, his body mass index, neck circumference, Epworth score. This helped to categorize the patient and reaching final decision about the patient's condition. Then we go for the full polysomnography or sleep study device, which is a sleep diagnostic and therapy device, flexible and reliable, easy to use system in the sleep lab or in the patient's home. All these electrodes in the patient head, patient face, patient chest help to record many parameters like EEG for the brain activity, EOG for the eye activity, EMG for the muscle activity of the mandible and face, cardiopulmonary parameters like ECG, airflow, and oxygen saturation level. Home testing device. This is a new technology for ambulatory sleep study. Today, with the technology advancement, the sleep study can be performed either in the sleep lab or in the home, in the patient's home. But only the home-based study recording 4 channels, either airflow, chest and abdomen movement, oxygen saturation, and pulse rate. Then we calculate by the end what we call the apnea-hypopnea index, which is the most important parameter to reach for the diagnosis of the severity of the patient condition. Normally, it's less than 5 events per hour. In the mild cases, it ranges from 5 to 15 events per hour, moderate between 16 and 30 events per hour, moderately severe between 31 and 39, and the severe sleep apnea over 40 events per hour. Here we go for the treatment dilemma. Which come first? We go for the treatment of the sleep apnea first, or we have to reduce the weight and make lifestyle modification and maybe go treatment of the other comorbidities that present with the sleep apnea first, or we go in a parallel way, which is with each other. So either lifestyle modification, weight loss, avoid sedatives and alcohol, body positioning during sleep, or using a CPAP machine, which is continuous positive airway pressure, or BiPAP machine, which is bi-level positive airway pressure, or to put orthodontic devices during sleep, or we go for the surgical option. Before using CPAP machine, we have to do what we call the CPAP titration to assess the patient level and the advisable pressure for the machine to be directed toward the patient during his sleep. This is the different models for the CPAP machine. And this is how the airway pressure helps to open the closed upper airway during patient sleep. This is an example of what we call mandibular advancement device. It prevents upper airway from collapse by protruding the mandible forward, altering the jaw and the tongue position. They predominantly increase the volume of the airway at the level of the velopharynx. The airway space is mostly enlarged laterally, throughout to be due to the traction of the soft tissue. Advantages of the mandibular advancement device: it's simple method, no special equipment needed, flexible in nature, success rate between 50 and 80%, easy to use, and average lifespan of the device between 12 and 18 months. Another important diagnostic method is what we call the sleep endoscopy. This is usually before the surgery, and to localize the exact level of the airway obstruction that's supposed to be targeted during the surgical option for treatment. There are many methods or options for surgical treatment. The aim of the surgical treatment is to remove the cause of obstruction, but through a reconstructive procedure. For example, adenotonsillectomy, this is preferred treatment in children, turbinoplasty or septoplasty, nasal polypectomy. There are methods like uvulopalatopharyngoplasty, which is now obsolete method and replaced by other techniques like lateral pharyngoplasty, radiofrequency ablation of the pillar, sometimes in advanced way of treatment. We put an implant that gives like an electrical activity in the upper airway or base of the tongue. Once the patient start to have collapsed airway, this implant gives an electrical signal to open the airway. Or in the end, we may end up in doing tracheostomy in patients with collapsed upper airway that are not candidate for surgical treatment. As a conclusion, we say that sleep disorders or sleep apnea are unfortunately common, serious, but thank God it's treatable, and unfortunately it's underdiagnosed or misdiagnosed. So in untreated obstructive sleep apnea condition or patient, they may increase in the morbidity and mortality throughout either heart, circulatory disease, or God forbid, an accident. At the end, I wish to all the audience a deep, restful sleep. And I repeat my thanks and gratitude for the scientific and organizing committee, and wish to see you all in the coming IMDO, inshallah. Thank you.
Thank you very much for the very nice and informative talk. I can't see any questions on the chat, so shall we wait for the end of the session? Okay, shall I introduce Dr. Wahab? She's a researcher in molecular medicine, a former assistant professor of College of Health and Sports Sciences in University of Bahrain, and she has a PhD in molecular medicine from Arabian Gulf University. Dr. Wahab, if you're ready, we can go ahead with your talk.
Yes, good morning, everyone, and thank you for introducing me. I just want to make sure that I have shared the screen, and if you can see it, please let me know, so I'll put it in the slideshow.
We can see that and we can hear you. Thank you.
Yeah, okay. Okay. I'm trying to reduce. Yes. Okay. So good morning, everyone. My topic is about the serum protein profiling that revealed gender differences in Bahrainis with type 2 diabetes. This is the presentation outline. This work was done by a number of authors, and it was a collaboration between Al Jawhara Center, Arabian Gulf University, and the proteomics unit at King Faisal Specialist Hospital and Research Center in Riyadh. As we know, that type 2 diabetes is a highly prevalent metabolic disorder, and it's a chronic disease that associated with micro and macrovascular complication. And cardiovascular disease is a well-established risk factor, and it is the most important cause of death in diabetic patients. And the disease is characterized by complex disturbances in glucose and lipid metabolism that results from combination of resistance to insulin action and or inadequate insulin secretion response. The prevalence of diabetes is very high all among the world, and it is very high in the MENA region. And the top 10 diabetes prevalence countries are in the MENA region. They are, four of the top diabetes with highest prevalence are the MENA region: Pakistan, Egypt, Kuwait, and Qatar. And of course, the diabetes is very high in the Arab countries as well, because we are part of the MENA region. And in the GCC, the prevalence is high, and Kuwait and Qatar are the leading countries, and then followed by Bahrain. Also, the diabetes prevalence is different between women and men in different countries and all over the regions or all over the world. So type 2 diabetes provide an interesting and significant example on how sex, and so we can call type 2 diabetes as a sex gender disease, because it is providing an interesting and significant example of and how gender and sex can influence the pathophysiology and therapeutic response of the disease. And those differences have been reported in diabetes, affecting diabetes epidemiology, risk factors, as well as cardiovascular complications that's associated with diabetes. So the reasons for that such differences or the SAC differences remain unclear, and the guidelines used by the clinicians or the physicians for diabetes treatment do not differentiate between sexes. And the possible causes for those differences or the outcomes is the differences in pathophysiology, treatment responses, and the psychological stress. So the biological sex differences and the clinical outcome are caused by genetic and hormonal influences on the pathophysiology, clinical manifestation, diagnosis, and as well as the response to the therapy. So in this figure, we can see the risk factor, the risk and this type 2 diabetes risk factors and risk predictors, diagnosis, the clinical feature of type 2 diabetes diagnosis, and psychological factors, how they are differ between men and women. We'll take just one example of each maybe. If talking about the risk predictors, we can see that always women, are having more visceral adipose tissue, or the visceral adipose tissue and the waist circumferences are more risk predictors in women than men. Looking at in the middle for the physiological parameters, we can see women are having, or men, they're having more visceral adipose tissue, or they can represent by more visceral adipose tissue and more insulin resistance, while women, they will be having higher adiponectin, higher leptin, and higher brown adipose tissue. For the diagnosis, always men are diagnosed more than women for diabetes, and they will show more fasting glucose, impaired fasting glucose, where the woman will be showing more impaired glucose tolerance. The clinical feature at type 2 diabetes diagnosis, the clinical features at type 2 diabetes diagnosis, women always have higher hypertension, and they will having higher obesity and excess weight gain. But as we can for the age, always men or women that are having lower age at diagnosis than men. And the psychological factors, the women, they're having prominent role in that. They'll be having more diabetic stress and more psychological stress. So the prevalence of diabetes is increasing in both sexes, as we can see, but men usually are diagnosed at a younger and a lower body fat mass than women. There are about 17.7 million men diabetes than women, but women, they have growth receptor like the obesity at the time of their type 2 diabetes diagnosis, and logical factors or stress, as we said, it play more prominent role in diabetes risk. So according to the latest surveys, men are more at risk of diabetes as compared to women, if you exclude, of course, the older population. And there are lots of evidence suggesting that metabolic regulation
دكتورة رباب.
just I want to make sure, have you heard my voice? Because I felt that there was something going wrong.
انقطع شوي الصوت. It
Hello?
got disconnected a little bit. Yes.
Can you hear me?
Now, yes, yes. Maybe
يتقطع الصوت?
Just for a
but it
few
goes.
minutes.
It got
This is maybe
for like 5 seconds.
okay, but it's okay now. Can I proceed?
Please, yeah, please go ahead.
Yes, okay. I'll try to change my position and have better connection. I hope this will help. Okay, so as we said, metabolic pathways involved in pathogenesis of diabetes seem to be sex determined. So it also has been reported that estrogen protects women against metabolic disorder and from deposing them to diabetes, and of course protecting them against cardiovascular complication. But this protective action will be lost with menopause. HbA1c is more strongly associated with fasting glucose in women than men. Other parameters like age, waist, circumference, body mass index, systolic diastolic pressure, lipid profiles, fasting insulin and proinsulin, all this predict type 2 diabetes better in women. Looking at sex gender differences regarding complication and therapy, again, we can see there are differences between men and women in the complications. Women also always having higher relative risk of heart failure, cardiovascular disease, and
sorry.
yes.
We cannot see your presentation. We cannot see your presentation.
What happened? It was shared. Okay, I'll just go back and make. You can see it now?
Yalla, loading still. Yes, now yes. Slideshow,
Yeah,
please. Just put in slideshow.
Yeah, I know, but I think it was.
Yeah, if you would like to share the previous slide or 2 slides.
Yeah, just a minute. This one, have you seen this figure? No?
No, the previous one. Yes.
This one?
Yes, yeah. From
start from here. I start from here.
Yeah. Just keep it in the slideshow, please. Slideshow.
Yeah, it's a slideshow now. Yeah. Okay. I don't know what's going on really, but okay. I hope things will go better. Okay, so as we said, HbA1c is more strongly associated with fasting plasma glucose in women. Other parameters, age, waist circumference, body mass index, systolic diastolic pressure, lipid profile, insulin and proinsulin levels, all predict type 2 diabetes in women, better in women, of course, than men. Looking at this figure, we said we will see differences between sex regarding complications and therapy of diabetes. In the complication, we can see that the women, they are having more relative risk to heart failure, more cardiovascular and relative risk of cardiovascular disease and mortality than men. On the other side, we're having also that the relative risk for renal insufficiency and failure is also high in women, where the relative risk for albuminuria is more in men than women. Talking about the therapy, one of the major problems of the women is that they're under treatment, and they're having low treatment goals in the diabetes treatment. For the HbA1c, as we can see that women are having more the baseline, women they're having less HbA1c on target and more hypoglycemia. Looking at the drugs or used during diabetes, like metformin, women always having higher side effects with metformin and less adherence, where the men will be having higher HbA1c reduction with metformin. I don't know. Okay, so until now, the gender and sex, or sex and gender influences on drug response has been neglected, and all physicians, they are using one-size-fits-all model that's predominant both in research and in daily clinical practice. The clinical trials for the new anti-diabetic drugs enrolled only 20 to 40% of women, and some of those trials have no statistical power to verify whether sex gender may be related to response differences. So concerning diabetes, it should be noted that diabetic individuals, pharmacokinetics and pharmacodynamics change. Together, they may affect the absorption of the drug. Here are also some gender differences in the antibiotic drugs. As we talk about the metformin, we can see, as we said, men that are having greater HbA1c reduction, women that are having greater reduction in body weight. Adherence, women are less adhered to the therapy. The adverse effect, women are having more adverse effect like gastrointestinal symptoms and the increased hospitalization rate. And the same thing happens for the other type of drugs, where men will be having privilege over women or vice versa. So type 2 diabetes is characterized by insulin resistance and affecting protein metabolism. Now we're going to see differences. Is there any differences in protein biomarkers between sex and diabetes? We know that diabetes is a metabolic disorder, and it is affecting protein metabolism. And there has been a great interest in proteomic analysis of plasma and serum to identify and characterize protein biomarkers of diabetes. And for the protein identification, the most important development and technology is proteomics. So proteomics study is the study of interaction, function, composition, and structure of protein at their cellular activities. And using proteomics will help in identifying protein biomarkers that may lead to early diagnosis and more effective treatment of patients, to understand the pathophysiological process of the disease, as well as understand the function of the protein and their interaction in drug discovery. There are many researchers that have been published to identify proteins in type 2 diabetes using proteomics. This research has been started since 1990. As then we can see, those are proteins found in type 2 diabetes with the references or the research that are the studies that have been conducted to find those proteins. The researchers also, they have identified the protein or categorized the protein up onto the classes. So many of the type 2 diabetes protein that has been found are cytokines related proteins, or they're immune related proteins, or complement related proteins. Some of them, they are lipid metabolism or transport proteins, and inflammatory proteins as well. And as we can see, they are expressed in type 2 diabetes, whether they are upregulated or downregulated. Here in Bahrain, we have conducted a research to find differential expressed protein in Bahrainis with type 2 diabetes. This research was published in 2018. We have found 62 proteins that were expressed in type 2 diabetes, and 44 of them, they were upregulated in diabetes, 18 they were downregulated. And there was a very good separation between the non-diabetic and diabetic patients, as we can see here in the principal component analysis. And plotting each individual protein, we can see that the level of some identified protein are different between diabetic and non-diabetic. Some of them are upregulated. The blue one is the diabetic, the red one is non-diabetic, and we can see that some of them are upregulated and others are downregulated. Out of those 62 proteins, 25 proteins were previously reported to be associated with diabetes in the previous literature, and 37 proteins were not reported before to be associated with diabetes, and we consider them as a novel finding for diabetes proteomics. And some proteomics differences in male. Now I want to answer our question: is there any sex gender differences in the protein biomarkers? Yes, protein composition differences has been reported in males and females. And semi-comprehensive protein analytical technique development of serum proteome, male and female detected gender-based differences in serum protein composition, not only in diabetes, in all type of disease. Another study we have conducted and published in 2023, where we compare men and women, healthy men and protein profiling in healthy men and women, Bahraini men and women. We have found 11 proteins were upregulated in healthy women, and 9 proteins were upregulated in healthy women. And when we applied the IPA, the ambiguity pathway analysis, the functional characteristics and the relation of the 20 proteins with disease and other immune-mediated disorders were explored using this pathway or this analysis. So there was different pathways or different relationship of those proteins were a different type of disease. So the aim of our study, the study that I'm presenting now, is to investigate sex gender differences in protein biomarkers in Bahrainis with type 2 diabetes. So our samples, this is our samples, and our patients were diagnosed using the WHO criteria. Of course, only we take Bahraini male and female, and exclusion criteria was different diseases that are related or they are interacting with the diabetes. And the study was approved by Ethical Committee, Arabian Gulf University and Salmania Medical Complex. The method was that we took the serum sample of those patients. We did, because we are working the protein is very, serum is very complex sample and has lots of protein. So we did protein depletion to separate them into 2 different categories, depleted and non-depleted sample. And then we determined the protein to prepare the sample for proteomics. So the samples that was depleted was denatured in order to unfold the protein, and they were reduced and alkylated in order to avoid the refolding. And then the protein was digested, make them small pieces, and then of course we have used internal standards and then subjected to the protein identification technique or machine, which is LC-MS, liquid chromatography tandem mass spectrometry. And then the results from this analysis was treated by bioinformatics. So we have done absolute quantification and by applying algorithms and using non-protein, which is internal standard, that was spiked with each sample in every run. And the proteomic data and bioinformatics was used. We use a software for the proteomic data analysis. And then the protein database search was used in order to identify those proteins in our samples. Gene ontology also was used to classify the identified proteins into different categories, like molecular function, cellular location, biological process, using bioinformatic tools. This is the clinical and biochemical demographic characteristics of our study samples. And looking for our results, we have found seven differentially expressed proteins that were upregulated in serum of female more than male with a very high p-value, as you can see. And 15 proteins were upregulated in serum of male more than female. So this was the finding of the study. And doing the gene ontology analysis, we have found that majority of the protein that was in the male samples were heparin binding protein and heme binding protein, if we talk about molecular function. And for the female, mostly they were antigen binding protein and receptor protein, yes, RNA binding protein and receptor protein. Looking for the biological process, majority of the proteins in the male samples were transport protein, where in the female samples, they were immune system protein. For the subcellular location, where they are located, the majority of the proteins in both sexes were in the extracellular region, but more in the female than male, and more cell membrane location in male than the female. So a total of 22 serum proteins were identified, and they were being differentially expressed in Bahrainis, men and women with type 2 diabetes. Out of those, as we said, 7 associated with upregulated in women, 15 upregulated in men. And the identified proteins involved in the immune system, lipid metabolism, transport, and the post-translational modification processing. The most notable observation was that the immune class of proteins was highly represented and markedly regulated in Bahrainis, men and women with type 2 diabetes. And as we know, the role of immunity is bimodal in diabetes. Immunity could contribute to the pathology of type 2 diabetes. And by contrast, the suppression of immunity is also one of the major consequences of type 2 diabetes. Of the other identified immune-associated proteins, the CD5 antigen-like was reported to be associated with atherosclerosis in type 2 diabetes in previous study. And also serum amyloid P component was also found to be associated in the progression of retinopathy in type 2 diabetes. For the HB-associated proteins, only HB subunit alpha has been previously indicated as a biomarker for type 2 diabetes. Vitronectin, which is a cell adhesion protein, identified in the present study, was reported to be associated with the metabolic syndrome and type 2 diabetes. We have also, in our study, transthyretin classified as transporter protein, which is expressed in type 2 diabetes. And this observation was consistent with other reports that shows association between this protein and diabetes mellitus. 2 proteins involved in lipid metabolism and transport, which is ApoB100 and ApoC2, that were differentially expressed in the present study and had previously been associated with diabetes and its complication. So a detailed investigation of the other proteins may provide insight into the understanding of the pathogenesis and the pathophysiology of type 2 diabetes and insulin resistance, since each of these proteins have a non-physiological function. The identified proteins could be involved in the pathogenesis of the disease or serve as disease biomarkers. The data reported in the previous literature and this study show that sex-gender approach in medicine is mandatory. And this suggests the need to have different therapeutic approaches for the management of diabetes-associated complications in men and women. And to maximize the scientific rigor and value of the research, it's mandatory to include the sex and gender in both preclinical and clinical research to ensure the health equity. Type 2 diabetes is a heterogeneous disease, and due to insulin resistance and some degree due to insulin secretion defect, and has a range of risk factors, etiologies, and clinical manifestation. So one size fits all approach is used to treat most of the form of diabetes, and diabetes treatment need to be more patient-centered, and precision medicine in diabetes need to be a reality. In 2018, 5 novel clusters of proteins of diabetes with different clinical features have been identified and was published in the Lancet. So clustering of diabetes is not sufficient to lead to change in diabetes treatment guidelines. In addition, it was noted in those clusters that they were genetically distinct, meaning that there was no genetic mutation that were shared across all the 5 clusters. So there is an urgent need for custom delivery of healthcare with tailored treatment of the level at the level of individual or at least the population. So in the case of diabetes, clustering of the disorder has now been identified as the first step in precision medicine. The second step precision medicine will be investigating the molecular underpinnings of each subgroup by using omics platform in order to categorize the patients based on differential responses to drugs. So in this study, proteomics profiling of serum have provided novel data toward discovery of proteins that may be potentially useful as biomarkers for type 2 diabetes in Bahraini population. And with the availability of the big data and analytical tools like genomics, proteomics, precision medicine is now slowly becoming a reality in the near future. So for type 2 diabetes, precision diabetes promises to be of use in personalized therapy of people affected with the disorder. Few studies to date have focused on sex-gender differences. Several questions demand further study. such as whether risk factors and treatment guidelines should be sex-specific, and there is a need for clinical trials designed specifically to evaluate the sex differences in the efficacy and the outcome of the available treatments. Clinicians and researchers should consider sex and gender in their approach to diagnosis, prevention, and treatment of the disease as a necessary and fundamental step toward precision medicine, which will benefit, of course, men's and women's health. And these are the references, and thank you for your attention.
Thank you, Dr. Rabab, for the informative presentation. Thank you so much. Dr. Molinat, you would like to add something?
Welcome.
No, it's fantastic. A very, very nice talk. And it's
Thank you.
interesting to look at the immune-related peptides being more in women. And we know that the immune-mediated diseases are more in women. And that is something very interesting that you have found a similar sort of theme thing even in patients with type 2 diabetes. Because what we know is there was a very nice study from US, which they showed that the younger patients with type 2 diabetes had more antibodies. So that the immune-related stories coming back again, which is nice to see. No, thank you.
Welcome.
Okay, Dr. Molina, this our first session ends with Dr. Rabab. We are going to start our second session.
Thank you.
هلا فيكي دكتورة.
Okay.
We have Professor Ali Al-Hamdani and Dr. Amr Al-Dirazi. So I think Dr. Ali Al-Hamdani, are you there?
السلام عليكم وصباح الخير.
صباح النور دكتور، هلا شلونك؟
سوري
شاء الله
يمكن بالنسبة لكم يمكن مساء الخير، نحن عندنا بعدنا الفجر.
لا we're still morning. It's 11 a.m.
I just prayed the Fajr prayer. I'm ready.
ما شاء الله، الله يتقبل يا رب إن شاء الله. Okay, so I will just introduce you, Dr. Ali, so you can start your lecture.
Thank you.
So for the audience, Dr. Ali Al-Hamdani, he is a consultant bariatric surgeon working in London for the past 13 years. He has an MD in molecular biology from the University of Wales. Dr. Ali has more than 300 publications and presentations in the national and international conferences. He is one of the leaders and organizers for the international teaching fellowships with the Association of Oxford University and the International Bariatric Societies. Dr. Ali has performed more than 3,500 primary and revisional bariatric procedures. تفضل Dr. Ali, the floor is yours. You can share your slide.
So, Dr. Iman, can you see this one? Yes?
Yes, doctor. It's clear and your voice is good. Clear.
Perfect.
Yeah.
وصباح الخير مرة ثانية، ويعني أنا كلش grateful for this invitation. It's really kind of you, and it's a privilege to present here and be with you for the, I think this is the fourth time now. It's really a pleasure.
Yes,
really a pleasure.
Yes.
And I always remember Bahrain. It's my second country. I love it. So again, many thanks for this. And I think I will try to take your mind away from diabetes and the very detailed lectures, and I'm going to take your mind completely different way, completely something far away. And I'm not sure actually how big is this problem in Bahrain medical tourism. In UK, this problem is present, but even in UK, the magnitude and the complication of medical tourism actually is massive, exactly like this iceberg phenomenon. So nothing to disclose. This is my case mix. I'm going to show you four unfortunate events or cases. Two or three of them actually are life-threatening complication, and one of them is bad results as a result of medical tourism. So maybe just to start with this one. This is a 46-year-old lady who had a mini gastric bypass in 2015, 2019. after the outside UK, had dropped her weight significantly after the operation from 110 to 41 kilograms within literally 4 months. She could not actually tolerate anything. She was vomiting consistently, feeling nausea consistently. And the surgeon in that country did different things. He did a CT, did an OGD, repeated CT. He could not find any problems. The patient becomes so emaciated after 4 months, and she's really was to lose her life. And the surgeon even at the stage thought of referring her to somewhere like psychiatric care. So to give you an idea what the problem is with this operation after the mini gastric bypass, the way we do the mini gastric bypass is we create a gastric pouch here on the top part of the figure, and then bring a loop of small bowel and anastomose it to this gastric pouch to the way that the gastric pouch will preferentially drain to the distal bowel. And with the bowel movement from proximal to distal, that will help actually to move the food towards the distal end of the small bowel. And that's the way it works. Now, luckily, the patient had a video of her original operation. So I'm not going to show you obviously the whole video. I'm going to show you maybe a minute there. And just put this figure in your mind and look at this current video. So this is the video. Now, this is the large bowel on the top, and then the surgeon here tried to count the small bowel on the bottom before he joined into the stomach pouch. So he done the stomach pouch already, yeah? So he started to count the bowel, and just look, the left part of the figure is the proximal small bowel, and this is the distal small bowel on the right hand. That's the way he counting it. So again, this is the distal, this is the proximal on the left again. So what he does now, he actually connects the pouch into this part of the bowel, which you remember, this is the proximal part of the bowel. Yeah. So he made a joint between or preferentially, the food coming from this pouch down to the proximal part of the bowel, if you remember the first figure. So what he literally did is this. He connected the pouch, the gastric pouch, to the proximal part of the bowel. And if you can imagine, preferentially, the food will go into the proximal part, which is against the small bowel movement, moving from proximal to distal. And therefore, the food is going always up and down. And that's why she was vomiting. Obviously, she came to us and we repaired. She came to me afterwards, and I revised this joint. But it's maybe a simple mistake, but actually the patient was about to lose her life. So what is medical tourism? So medical tourism, patients travel outside their country seeking medical treatment. And the main attraction in UK, for example, patient is the low cost of the treatment outside the UK. And also the very long waiting time we have in our National Health Service, specifically even after COVID. The waiting time for bariatric surgery is average 3 to 2 years, 2 to 3 years. So it's that long time. And internationally, this become a very attractive business. So it's really bring to people who are doing it about 400 billion per year. We're talking about 14 to 16 million patients doing this type of operations. And there are actually new medical tourism companies. It's a massive business. And these specialized medical tourism company provide low-cost international travel, consultation all over the world. If you can imagine, we have in Harley Street offices rented by international doctors who provide medical tourism. But if you can imagine, these doctors are not even registered in our General Medical Council. And the reason behind that, because they're not providing medical treatment inside UK, but they're allowed to obviously to rent a flat or a house in Harley Street and talk about medical tourism and offer it to patients. Obviously, in the countries where they offer medical tourism, it's very low cost. It's low wages for doctors and also very cheap malpractice insurance, significantly, and that's why they can afford having the such prices for the operations. And I can give you just a simple example regarding malpractice insurances. So I pay for my malpractice insurance in UK about £45,000. So is that expensive? So give you an example, what's the cost? The average cost of sleeve gastrectomy, تكميم أو قص المعدة في ال UK is about 10 to 11,000 pounds. In Eastern Europe, a third of that price. So it is a significant attraction to people actually who would like to have this type of surgery to go outside UK and do it. In US, they even have made the insurance companies has made an agreement with overseas providers. So some of the US insurance company had the patients go to, for example, to Mexico and have the treatment there. So it is a massive business. So before the operation, usually the patient here seeking weight loss surgery, word of mouth, online advertisement, social media. British patients usually travel to Eastern Europe in general. It's a close travel, it's about 2 to 3 hours travel, and they can get their operation there. So I'm going to talk about medical tourism problems before and after the operation, and before the operation. So what's happened before the operation? If you can imagine, the preoperative education is really minimal. So they talk to the patient. After a few days, the patient traveled to have the operation. So very minimal preoperative education. The patient will not discuss properly in multidisciplinary meeting. The consent, I have significant doubt about it. There is no translators in a large amount of services. So the amount of information that's given to the patient is really minimal. When you go to the hospital and see it, actually some of the hospitals lacks intensive care, lacks interventional radiology. I'm going to show you in a second, some of the operation even they offer it is not actually recognized in UK, for example, as an operation there. And in the international community as well. There's no NICE. NICE is in UK is the National Institute of Clinical Excellence. So it's a governance body, let's say, that can actually regulate the medical supplies, the surgeries that is done. So these countries, some of them at least lack such organization. What about after surgery? So when I see the patient after surgery who come to me, I can't see an operation note. And even if I see an operation note or discharge summary, it's in different language. The follow-up, I'm not sure what type of follow-up is arranged. Obviously, it's not face-to-face. It's maybe virtual. And the regularity of the follow-up is also in doubt. Patient had very poor understanding of the multivitamin and supplements that they need to take after the operation. Poor results, obviously, large amount of patient need corrective surgery afterwards. And don't forget, people, when they travel, there's a chance they develop clots in the leg and clots in the lungs. Now, this is not the main part of the after-operation problems. The main part of the after-operation problems is the high morbidity and mortality. That's the main problem. And just to tell you also another angle of this problem is when they come back to UK, the surgeons in the UK have difficulty dealing with those patients. Why? Because the surgeon in general, they're not keen taking these patients, because when they take these patients to do an operation on them, and this complication will be registered by their name, by the UK surgeon name on our national database registry. So if a patient comes to me, they have an operation as a complication from outside the country, it will go on my record if there's a problem with that. So that's kind of understand the surgeon is not very keen on taking such patients. The cost for the hospital if the patient come, for example, with a leak or with a bleeding and stay for 4 to 5 weeks, it's more than £100,000 per patient. So it's a massive on the National Health Service, massive cost on the National Health Service. Sometimes we go inside after complication to look what's happened, and we don't even know what's the primary operation. So it's like a guesswork, really. That's, apart from saying that treating such complication is obviously very difficult and requires not a junior surgeon. You need a very senior surgeon to deal with such problem. Now, I'm going to show you what I mean in a second. So this is, again, an unfortunate 36-year-old lady. She had, what I could understand from the patient at the time, maybe a sleeve gastrectomy outside the UK. 3 days post-operatively, she traveled from UK traveled from that country to the UK, back to UK. 3 days. It's not even stayed for a long time in that country, which is against any international advice about travel post-operatively. Anyway, she traveled to the UK. with severe abdominal pain. I'm not sure how did they allow her to leave. She arrived at Heathrow, straight to my hospital. And just have a look. This is her observation on arrival to the hospital. She was literally in septic shock or septicemia, temperature 38, CRP 300. The CT scan doesn't, the radiologist called me from the CT scan, Ali, please take this patient quickly to theater. There's a large lump in her left upper quadrant. So I'm going to show you the video in a second. So when I went inside, this is the video inside. I saw this big lump there. And you can see this big lump is pressing on. First, it's necrotic. You could, it's a black color or dusky color bowel. And second, you can see it's pressing on the liver, pressing on the pancreas there underneath, the splenic artery just far away, pressing on the spleen. I'm going to show you that in a second. And I really didn't know what I'm facing with. And I'm just trying to take it gradually and take the adhesions away. And you can see now the discoloration. This is black looking or dusky looking in comparison to the small bowel. This is the spleen. So it was flush, pressing the spleen. And look at my dissection here. Very, very, very difficult and very demanding. This is the heart, by the way. And you can see this is not normal bowel. This is black color bowel. And what this lump is that this surgeon has cut the stomach and left it, forgot to take it out. Can you imagine? I mean, I would always maybe see this complication as something you can mention or think about, but physically seeing it, it's really difficult. Fine. This is a case actually of bad results and an operation which is not done in the UK. This is a 40-year-old gentleman, came after 6 years to me with history of having laparoscopic gastric plication. He did not lose any weight, and you can see his BMI is much about the same, and he came for the revision. So I'm going to show you this case again. So this is the gastric plication or laparoscopic gastric plication. See if it works, sorry. So what we do with the gastric plication is we separate the stomach from this side and then make sutures in the stomach wall to decrease the stomach size. But we don't cut anything. It's not like a sleeve. And you can see from inside that this is when I took him to theater. This is myself doing the operation. The stomach size is much about the same. And to do anything, we physically have to take these sutures out. So because these sutures are permanent sutures and stay for life. So doing any revisional surgery is nearly impossible because if we apply our staple line against the suture, there will be high chance of having leaks or bleeding. So the complication will be high. So the only way to do any operation revision is to take the whole sutures out from top to bottom of the stomach. And then also afterwards, we have to take this part, which as you can see is, again, it's not very healthy. And then I can do the revisional surgery, which is this is the one in this case. The bypass. So again, it's a demanding operation. There's a high chance of having problem with the revisional surgery. And again, this operation, which is gastric plication, is not actually authorized by the NHS England to be done in the UK. So again, now another example. This is a 33-year-old lady who had abdominoplasty outside the UK. This happened only 2 months ago. She had the operation 6 months ago, coming to A&E, again, with feeling a lump in her abdominal wall, very painful lump, and it's about to get swelling a bit in that lump as well. So I asked my registrar to take an X-ray, and I'm going to show you the X-ray now. So this is what the X-ray shows. I thought initially my registrar was joking. I thought this is not an actual X-ray. Look, this is a large artery clip, which is inside her abdominal wall. I thought this cannot happen. So I thought there's something wrong here. Let's do a CT. And that's the CT, just confirming the finding. It's a large artery clip in the abdominal wall. So we literally took the patient to theater and take this artery clip out. This was unbelievable. I could not actually believe my eyes when I saw this patient. So this from the BBC. It's actually the Foreign Office has issued a warning for any patients who travel to a certain country after 20 UK patients died having their operation from 2019 till now. It is a serious problem, as I said. So medical tourism, it's obviously there is a place for medical tourism. However, currently there's no international guidelines to regulate this problem, this service. Obviously, there's no continuity, there's no post-operative care. It's really difficult to get access to patient medical and surgical notes. The patient has not have enough education, or maybe the language barrier, and also the before and after information not given properly to the patients. This is all part of the medical tourism which is happening now and internationally. And if you think it's not, this medical tourism is not exactly, the patient need to think a bit more apart from the cost, really. It's essential part of weight loss surgery to have multidisciplinary approach, preoperative education, continuity of care for a long time. This is not present in this type of treatment that they're providing to the patients. And I can just maybe finish by saying why these patients are seeking such treatment, why they have to travel such far away distances to do the operation. I can tell you that when you meet those patients, they are actually desperate. They see the other people losing weight and they are literally stagnant with their significant high weight, and they feel a failure. It's a significant failure inside their soul, and this makes them vulnerable. So this makes those patients vulnerable for other people and companies to approach them and use that for their own, or abuse it, let's say, for their own interest. Well, these patients literally only want to be healthy and want to be safe. Thanks a lot for listening. That's very kind of you again. Thank you.
Thank you, Professor Ali, for a really nice presentation and being in time. Well, it's a topic of, it's very important to look for the way to do the surgery. And I cannot imagine that you do surgery and you just travel next day and you get you will not get the proper follow-up or a surgery. But the problem is the big demand for doing the bariatric surgery first. And the second one is the, as you mentioned in your lecture, the cost for some patients and the necessity for doing this surgery. So if there is any idea or there is one, we'll say, website who can guide you to the proper approach for the recognized obesity surgery, or the way, or maybe even your patients, they will ask you if they are a long waiting list, what they can do. So what you recommend for them?
شكرا حبيبي أني دكتور أسعد, and many thanks for the invitation again. It's really nice. It's really lovely talking to you and see the Dr. Iman and other group there. You're amazing. المشكلة شنو؟ المشكلة أنه الكوست مال يعني هم احنا عندنا national health service, so all the patients, majority of the patients, let's say 70% of OE UK patients go to the national health service. المشكلة بال 30% of the patients who cannot access or reach the national health service because of the long waiting time. If you can imagine, 30% is massive. Specifically, the UK obesity is literally 26% are obese in the UK as average, 26 to 28%. So it's massive population. We're talking about 60 million UK population really. So it's massive. So you can't control it. It's all social media now. So my effect is really minimal. You get these pop-ups when you look into your Instagram, when you look into your Facebook, they just come up as pop-ups. Even to me, I don't know why they send it to me, because when I open, I think because they see the word bariatric surgeon maybe. So even when I open my Instagram or open my Facebook, I have this pop-up, and it's very interesting pop-ups. You'll see a British patient speak fluently, obviously English, and he is in that hospital having his surgery, and the price there starts from £2,000. So I will think many, many times before accepting a UK package of £10,000 and refusing this package of £2,000. It's literally non-brainer. Specifically, if my neighbor had the surgery there, or on my family, one of them had the surgery there, or a friend of mine had the surgery there. So it's really difficult. So the social media is so easily accessed. And even if yourself do the search, even if yourself go and look into Google and write, for example, weight loss surgery, and even if you write weight loss surgery London in Google, the first 3 sponsored advertisements will be coming from overseas, outside UK. So again, it's a massive problem. Of course, when the patient looks specifically to, for example, my name, they will see my name and they will look at my website and they look, for example, at my services or whichever. But that's only if the patients knows me. The majority of the patients, they go into these pops-up advertisement or the social advertisements or the Google search themselves. It's very difficult to prevent it. And therefore, the IFSO, the National Federation of Obesity Surgery, current plan is to have a body to put a guideline for international weight loss surgery. Again, this is very preliminary work, and even if it happens, I find it difficult to implement these guidelines. It's really difficult. How can you force people, for example, in low socioeconomic countries to force them to use this type of stapler or prevent them from using this type of operation? It's really difficult. The nice thing about Bahrain, I think the majority of your patients are, how do you do that? Is majority are insured, aren't they? So they don't need actually to go and to do that, aren't they? You're muted, Dr. Asad, you're muted. Yeah, I think I might
Okay.
be. Yeah, I can hear.
So basically, what happened currently, if you cross the bridge to King Fahd, the bridge to Saudi Arabia, they cover by the private insurance, so
Good.
they do it. But in Bahrain, not yet. Mainly through the government hospitals like Salmania and private hospitals. Well, for private, you need to pay for that. And I think they do also attract some patients from near countries. And further than this, some people, they go to Jordan, as I know, to do bariatric surgery. This is the main destination for the touristic surgery, if you can say.
Yes.
Otherwise, from Kuwait, some surgeons, they come to Bahrain to do surgery to their patients because the regulations in Kuwait, I think, is different from Bahrain.
Right.
For regarding BMI, this is what I can say.
Okay.
Mainly, yeah. So, as you mentioned, in Europe, they go from United Kingdom to other countries near to get less expensive cost. But here, it's a different issue, the indication. So, as I know before, surgeons from Kuwait, they come to Bahrain to do it for their patients. So,
Yes.
patients and surgeons, they come from Kuwait.
Interesting. Very interesting.
So, if you want to establish a bariatric surgery department, is it the surgeon who will initiate or the hospital? I mean, keep the service and how it is available, how many hospitals they can provide like such service.
So to establish a weight loss surgery service, we have in UK we have the tier system. So for example, we have 4 tiers, 4 levels, let's say, of service in weight loss in general. So we have level 1, which is let's say community support for the patients, like for example, physiotherapist, local trainer, physical trainer, something like this. Level 2, where the GP involved. Level 3 is, we call it medical weight loss management, like I think like something like an endocrinologist like yourself or a diabetologist who run this service. And level 4, which is the weight loss surgery. So in order to establish a service, you have to have this 4 tiers available in that part of the community to establish that service. And it's usually funded by NHS England. So the NHS England actually fund these four level of services in that part of the UK. But one of the problems again in the UK, I mean, it's a very heavily populated area, and the NHS, the National Health Service in UK is really struggling. When the COVID came, we have a significant hit back with emergencies. So we stopped all elective work for literally 2 years. So the weight loss surgery I'm doing now for patients who are actually on the system from 2020, 2019. So these patients have been waiting for 3 to 4 years to have the weight loss surgery. So we do have facilities to perform the operations. The problem is the priority for such patients is really late, as this is the priority for such patients is the last on the list, let's say, because the priority takes for the emergency, for the not well patients themselves, and the weight loss surgery come last. So, for example, even if I have a list today and I have 4 patients on the list, if an emergency come, it will take priority. If a patient with let's say severe cholecystitis who need his operation and severe inflammation or bad problem with the bowel, they take priority. So again, it's tough, and therefore these patients again, after waiting for 2-3 years, they will be cancelled. So, and again, these patients are really vulnerable. They feel they're failing, they're feeling they're not even now. They have to wait maybe another 6 months or a year. So you can't really blame them if they go outside. And that's why that's really important to have a very good education system. And I'm really happy that the Foreign Office in UK just issued this warning that I showed earlier, telling that people, please be careful when you travel to other countries, because 20 people died in UK because of this. I think there's a question from the...
Yeah, Dr. Molina would like to share.
Hi, yeah, thank you very much. Very, very nice talk, and especially talking about the medical tourism and this question about, we used to run a tier 3 medical service, obesity service in our hospital, and I'm from Bolton near Manchester. And the main thing is that the motivation for the patients to lose weight prior to surgery goes, because if they see that if the BMI is more, they will be prioritized. Why would they know that they won't be able to reach BMI of 27 just by diet and medicines? So if they can reach 50, they'll get the surgery. And why would they work? And this was absolutely blatantly told to us by some of the patients. Is you're telling me this to do this, it's going to sort of prolong my sort of lying in that list, and I won't be getting it done for next 5 years. And that's a practical problem.
Absolutely correct. That's the problem again, and I think it's the way the government in UK are funding the weight loss surgery. They literally have no. That's a really nice question. That's very, very good question. Because I don't believe myself that for example, delaying the patient for a long time will make any good for the patient. If anything, it will make the patient worse clinically and mentally. And the main reason I think is fund. The UK doesn't have the fund enough enough money to fund weight loss surgery. So they start to create these hurdles. So creating T3, asking the patient that you have to go and do weight loss management plan themselves for at least a year. If they don't do that, they will not be qualified. So I have a patient, for example, on the NHS who BMI of 45. She's got hypertension, so she's literally fit the criteria, but I cannot physically do the operation for her because my NHS England primary healthcare, they said, we're not going to fund the surgery unless this patient do 1 year of T3. So I'm stuck. So, and then This patient was waiting already 3 years on the system. Now, on the same patient have an offer to do the weight loss surgery outside UK for £3,000. So what shall I tell the patient? How can I convince the patient to wait another year and not do the surgery outside the country? I managed at the end to do it on the NHS after I show him this video that I showed earlier in my presentation.
No, absolutely fine for individual patients, but if you're looking at the bulk at the service,
Absolutely.
and as a clinical lead, we always had this problem: is that how to address it? And as you said, it's not only the timeline and the guidance. NICE is fantastic, but NICE puts a lot of binders to for what we do.
Absolutely.
In favor of the quality control. But the question is that the capacity to do enough of bariatric surgery in the UK is extremely limited. Even if
Absolutely.
we had the funds, we don't have the surgeons, the intensive care facility to do so many surgeries. And that is a big limiting factor as well.
Absolutely. It's a maximum, it's really limited. The significant limitation, number of surgeons, number of staff. We are inundated by the emergency still from COVID time. I mean, I can't see. We need literally a massive spending to improve the services. I mean, I'm being used right, left, and center to do something literally any other surgeon can do while I can do my weight loss surgeries. Again, it's totally agree. Totally agree.
Dr. Ali, there's a question
Yeah, thank you.
by Dr. Qusay. He's
Dr. Qusay?
asking that he has seen many patients with gait walking problem after bariatric surgery. Do you have any comments about this or
Yes.
any observations?
Yeah, I mean, it's multifactorial problem. And if you can think of it, there are many reasons for that. For example, let's say B12 deficiency, as simple as that. Are they patients regular on taking the B12? Is it measured regularly? Is it in the correct level? By the way, B12 normal levels start from 200 something, but in weight loss surgery, we aim for the B12 to be above 400. And the reason is that is the bioavailability of the B12. It's better to have a higher concentration to make sure that the body using the right amount of it. So the B12 normal level doesn't mean it's normal after a bypass, for example. It have to be above 400. There's only one of the reasons. There are many reasons. Is the patient malnourished? Is there a wasting of the muscles? Is there a protein deficiency? So having a normal weight patient doesn't mean that they are not protein deficient, and that affect the muscle, and that's by the end actually cause muscle wasting, because they might have large amount of fat. The way they're eating, they're maintaining the fat mass, not the muscle mass. So there are multiple factors really. Obviously, in the operation itself, it could be an injury itself, because the patient, the way he's lying on the table for some time, it can cause neuropraxia, damage to the nerves. So this is all possibilities, and that's why it's a multifactorial problem. It's not only one reason. In general, they have to have a very good gastroenterologist on board of the service, so he can actually investigate all these causes. Yeah, thank you.
Okay, by this, we would like to thank Professor Ali for your interesting lecture and even for the discussion. And if there is no more questions, we can have, a rest until next session. It will be after 30 minutes.
Thanks a lot again,
Okay.
Dr. Asad and the team, for this invitation. I'm really privileged to have this today. And as always, I love to come and see you guys anytime.
Okay, thank you very much.
Thank you.
Okay, bye-bye.
Dr. Asad, the break we'll start again our third session at 12:15.
Great, okay.
Yeah.
So, 30 minutes break. Okay. Thank you, all of you.
Dr. Huda Omran. Hello, everybody. We're back to our third session. Dr. Asad, you want to introduce Dr. Ahmad, if you don't mind?
I can introduce him. Hi, Dr. Iman. I can introduce him if you don't
Yes,
mind.
yes. Okay. هلا دكتورة ما شفتك online. هلا بيكي. يلا
Okay.
تفضلي.
Okay. Good morning, good afternoon, and good evening as we approach our last session in the amazing IMDO conference in its sixth edition. We have 4 distinguished speakers. The first speaker is Dr. Ahmed Esbai. Dr. Ahmed is the highly respected consultant of internal medicine and has extensive experience in Egypt and Bahrain. He worked as a consultant of internal medicine in Egypt from 2006 till 2013. Since then, he has practicing in Bahrain at Al-Kindi Specialty Hospital. Dr. Esbai is known for his exceptional clinical skills and dedication for staying updated with the latest advanced in the internal medicine. Today, he will have a talk about the reflex sympathetic dystrophy syndrome. Dr. Ahmed, the floor is yours.
Okay. Good afternoon, everybody. Actually, I am proud to talk in front of you today through this video camera. And I want to thank Dr. Wahab, Dr. Asad, and all the scientific committee of the IMDO. Okay. Yes. Today I'm going to speak about algodystrophy, which is a reflex sympathetic dystrophy syndrome. Okay. Maybe it is not a common diagnosis to me, okay, but in clinical practice, we are meeting a lot of cases of reflex sympathetic dystrophy syndrome. Let us go through and to know everything about this issue. Definition: this is a complex of symptoms characterized by severe pain, swelling, autonomic dysfunction, and impaired mobility of affected joint areas. Algodystrophy may occur following trauma, but also occurs without any obvious precipitating. There are a lot of synonyms of algodystrophy: causalgia, acute bone atrophy, post-traumatic painful osteoporosis, shoulder hand syndrome, Sudix disease, Sudix-Lyric syndrome, Steinbroker syndrome, decalcifying reflex sympathetic dystrophy, and etc. What about the epidemiology? It is observed in every race, occurs between 40 to 60 years, but can occur in children and the elderly. So it affects all age groups. In children, ladies or females are more than males. In adults, males are more than females. Lack of diagnostic criteria explains the lack of information on incidence and prevalence. Okay, what about the etiology and the pathogenesis? Pathogenesis is unclear, 100%, but there are numerous theories have been suggested. Disturbance in the autonomic nervous system is considered. So it is mainly, as according to the reflex sympathetic dystrophy syndrome, autonomic nervous system is considered. Any initiating or inciting factor will lead to excitation of abnormally responsive fibers which may provoke pathogenic. These injured axons have increased sensitivity to norepinephrine and other substances released by local sympathetic nerves. As what occurs exactly in hyperthyroidism, there is increased sensitivity to the effect of norepinephrine. This sensitivity is blocked by IV sympatholytic agents such as guanidine, which is an older drug. Okay, what about the inciting factor? What will lead to this dystrophy syndrome? Number one, trauma. Number two, which we are meeting in a lot of cases, is immobilization in plaster casts. So most of doctors like rheumatologists and sure orthopedic doctors who will meet this case. Cardiovascular system diseases as ischemic heart diseases, pleuropulmonary diseases, hyperthyroidism. Hyperthyroidism also is a very, very common cause of reflex sympathetic dystrophy syndrome. Anti-tuberculous drugs, pregnancy and postpartum, so we can meet a lot of cases like this. Emotional stress, diving in water, and electrocution. We have two very important predisposing factors to algodystrophy: diabetes and hypertriglyceridemia. Okay, let's go to the clinical features and the presentation of the patient. There is pain, swelling of one or several joint areas, usually unilateral. Okay? Autonomic vasomotor disturbances are present, as we have tight, shiny, warm, and blue skin. There may be pallor or cyanosis, baldness, non-pitting edema, and hyperhidrosis. So a lot of clinical manifestations, and all are variant, and it differs from patient to patient. And according also to the stage at which the patient is presented, and this will be discussed later. Sensory disturbances are variable, but there is often a glove-like hypothesis. Okay, let's look at the right foot. This is a typical case of algodystrophy. You will see the left foot, reddish, and there is also hypertrichosis. This also, the left upper limb, with a lot of hair and change of color. This is the patient is coming with this picture with severe pain. This shoulder hand syndrome. The radiographic picture of the affected joint area shows late and inconsistent demineralization in a patchy or diffuse distribution after several weeks or months. So when we are seeing the patient after several weeks or months of start of the disease, we will see demineralization. And we have one X-ray, which I will show it later. In affected joint, the capsule shrinks so that movement is very bad. Mobilization of such contractures aggravates the condition. And this is what happens usually if you are putting the limb in a plaster cast due to fracture of something. Okay, as you see, the head of femur here. Okay, on the side there is demineralization mentioned. The involved area is not limited to dermatome, myotome, or to peripheral nerve distribution. It may involve one or several joint areas, especially a foot, hand, knee, shoulder, and even the spine or anterior chest wall. So all joints and all bone all over the body may be except the skull. This is the staging or progression. Okay, Steinbroker, even the name of algodystrophy, one of its synonyms is Steinbroker syndrome. Number one, stage of hypertrophic stage. Early, the patient will come with pain, edema, swelling, hyperhidrosis, warmth, and redness. Then, weeks later, he will come with atrophic stage, pain, cyanosis, atrophic skin, baldness, and articular surface. And Lastly, in stage 3, lately, there will be atrophic skin, coldness, articular stiffness, lipid or not lipid. Okay, they put, a diagnostic criteria, maybe by the American ARA or American College of Rheumatology or something like this, put criteria to diagnose algodystrophy. Group A, local, mechanical, inflammatory or mixed pain, cutaneous hyperthesia, vasomotor disturbance, skin changes, increased or decreased hair or nail growth. So there is variability, as you see, there is variability of presentation. Increased hair, decreased hair, nail growth, local original hyperhidrosis, local original edema, aponeurotic capsule, or tendinous contraction. Group B, local homogeneous or heterogeneous bone demineralization, as we see before, without narrowing of joint space. So we can differentiate between osteoarthritis or something like this, or other pathology. Sorry for this. Local increased or decreased uptake on bone scintigraphy, and we will see, scintigraphy later. Okay, there is increased or decreased uptake. Group C, no laboratory signs of inflammation. This is a non-inflammatory process, so we can differentiate between this pathology or this disease and the other inflammatory disease like rheumatoid arthritis and this. Group E, few cells in joint fluid, vascular congestion with no marked cellular infiltration, revealed on synovial histology. So if we will take a histology of this, we can differentiate between algodystrophy and other joint fluid, which contain cells like gout and pseudogout. Normal bone histology, rarefaction of the bone trabecular, hyperosteoclastosis or hyperosteoclastosis. So both osteoclasts sometimes are active or osteoblasts sometimes active. Dramatic effectiveness is very important. This is a therapeutic test. If we will give this patient calcitonin, which is the trade name is myocalcin, present in injectable form and intranasal, or long-term peripheral blockage with guanicidine. So if we will give this patient calcitonin, there will be a dramatic effect. Maybe after 4 or 5 doses, the patient will respond, and calcitonin is very important, as you know, its mechanism of action. It decreases or inhibits the osteoclastic activity, okay, and also it is a very good painkiller. So what is the differential diagnosis? The criteria were made to differentiate algodystrophy from other diseases as infection, inflammation, crystalline arthritis as gout, pseudogout, stress fracture, osteonecrosis, scleroderma, and epithelial contractions. The previous X-ray with demineralization of the head of femur, we must differentiate this from a vascular necrosis of the femur. As regards the hip joint, it is very difficult to differentiate between transient osteoporosis, which is algodystrophy of the hip, and the osteonecrosis or avascular necrosis, in which the same osteopenia of the femoral head can be observed in radiographs, with the same even uptake of radionuclide and possibly the same low signal area on T1 weighted MRI. So you can differentiate only by the T2 weighted image, in which algodystrophy displays a high signal as opposed to low signal seen in the. So in the T2 weight, the radiography of the radiographer or the radiography doctor will concentrate on T2 to differentiate between osteonecrosis and algodystrophy. Okay, what about the investigation to do with this patient? They are non-specific, as we see, normal ESR and something like this. This is not specific. We have radiography, also is non-specific. We cannot differentiate, as we see, between the algodystrophy of the hip and osteonecrosis. MRI may show abnormalities, and we discussed it before. What about bone scintigraphy? It will see initially increased uptake, then or decreased even uptake in children or young adults. So there is all the investigations, more or less non-specific, but with the clinical data, we can diagnose. There is vascular scintigraphy. What about vascular scintigraphy? There is increased count at the start, demonstrating increased blood flow due to vasodilatation. Then decreased counts due to vasoconstriction. This is a typical case of autonomic disturbance. What about thermography? Useful only in follow-up. There is increased heat emission or decreased heat emission early in children. So there is a variable pathology in adults than children. Vascular investigations, Doppler and capillaroscopy show variable vascular flow, also non-specific EMG variable also. So what about biopsy? If we will take a biopsy from the synovium, it will show hypervascularity and the absence of inflammatory cells. So we can differentiate between alpha-dystrophy and a lot of pathologies which are like rheumatoid arthritis, like pseudo-gout, like gout, and so are all inflammatory processes. In bone, initially hyperactive osteoblasts, then bone remodeling. So the osteoblasts are active, and then they will be remodeled. You see, this is increased scintigraphy. Here, you can see this is affected limb. Here was increased uptake. Okay, this is decreased uptake. So we can, in scintigraphy, we can find both increased uptake or decreased uptake. This is a thermography for the lower limb, thermography showing intense hyperthermia in the right. Okay, finally, what about the management for this patient? The management should start as soon as the diagnosis is established and before radiographic signs which appear later. So we must treat the patient as early as possible. Okay? When we are in the ICU and in a paretic limb or something like this, we are all meeting a lot of cases with non-fitting edema, unilateral. What is this? Should search, maybe it is algodystrophy. So non-steroidals for pain, mobilization of the affected joint and the limb to prevent disuse and frozen limb or like frozen shoulders and so. Vigorous physical activity or physical therapy with a physiotherapist. Or as we know all, when the etiology is unknown, we have to use cortisone. 30 to 40 milligram prednisolone in the first 4 to 6 weeks for 2 weeks. When the presentation, the early presentation, we can use corticosteroid in a medium dose, prednisolone, 30 to 40 milligram for 2 weeks. Yes, this is the golden drug to use in this patient, even if it's therapeutic use, calcitonin, 100 to 160 international unit per day for 4 to 6 weeks, followed by injection every other day for 3 to 6 weeks is better than steroid. Sure, but steroid has also a lot of side effects, and it is common. This disease is common in diabetics, so we will pass into uncontrolled diabetes and so maybe aggravated hypertension, even osteoporosis. Bisphosphonates, and we have a lot of bisphosphonates. Also the mechanism of action of bisphosphonates is the suppression of the action of osteoclast. Okay. Lastly, sympathetic block, either by drugs as guanidine if calcitonin fails, or by surgical sympathectomy if blockage fails. We can use anticonvulsant as gabapentin, okay, and IV regional anesthesia with clonidine. Thank you.
Thank you, Dr. Ahmed, for this interesting speech. I have actually one question for you. what's the prognosis of the patient with this sympathetic dystrophy?
Yes, as I mentioned, if you will pick the patient early, before we have demineralization of the affected joint or something like this, we can save the patient and we can save even the joint. Because if we leave the patient for a long time, till there will be, contraction or something for the capsules, as I mentioned, we may lose the joint. A lot of patients, we are seeing a lot of patients with this syndrome in the ICU and in fractures. So if we will, I suggest to use calcitonin as early as possible, and without maybe we will not find a side effect. As a therapeutic test, if we use calcitonin and the patient will improve, okay, you can go on and continue treatment.
Thank you, Doctor. Thank you.
Okay.
Okay, I have a question, Dr. Ahmed. Hello?
Yes, with you.
Yeah. So, Dr. Ahmed, for this, well, as you mentioned, uncommon presentation. So, what is the chance of, and what is the complication if we miss the diagnosis and we neglect like similar conditions?
Yes, actually it is the same question of our colleague, but by other way. If we neglect the patient or the diagnosis passed unnoticed, and sometimes we may lose the joint itself. If it affected one joint, it will lead to contractions of the capsules, and we may lose the joint, and we will get a frozen joint forever. The patient, especially something like the shoulder, and we are meeting a lot of patients like this, Dr. Hassan, especially in diabetic patients. So as early as possible, when we diagnose the case, we will save the patient and the complications. And even we can get disfigurement. In hyperthyroidism, this explains the case when we have something like the decreased hair growth or change of the color of the limb itself due to sympathetic dystrophy. This is even disfigurement. And also the pain. Okay, if the patient can tolerate the pain forever, I think no.
So how we can, well, you know that many conditions now, as diagnosis of exclusion, many of the cases, they also been diagnosed as fibromyalgia. Yesterday also, well, Dr. Basim also, he commented about missing cases of rheumatoid arthritis and even, well, overdiagnosis of some conditions to be as rheumatoid arthritis. So basically, well, there is a lot of criteria, as you mentioned, to give us a hint to diagnose these cases. What is your advice to pick up the cases? I mean, what is the signs and symptoms you want to stress on to get the trick of diagnosing these cases as early as possible?
When we, in ICU or in a patient in a plaster cast or something like, or a patient with diabetes, patient with hyperthyroidism, we can, during any clinical examination, we are examining the limbs, okay? If you find any change in color or distribution of hair in the limb or the swelling, usually there is non-pitting edema, involving even the hand of Dr. Assad, and sometimes the patient present with pain in the hand and the pain in the shoulder, which is called shoulder hand syndrome. And the patient may be presented to the ER with this severe pain, okay? So we can pick it as early as possible by searching for this, changing color in the limb, changing the hair distribution, and asking about pain and sometimes tenderness, okay? And with the history, if the patient is diabetic or not, have comorbidity like hyperthyroidism, and even the lipid profile, hypertriglyceridemia. We can pick the patient. And if there is doubtful about the diagnosis, Why you cannot start, as I mentioned, calcitonin? We will lose nothing. And if we will save the patient, we will get, a great benefit as a therapeutic test. Because even the criteria for diagnosis, as I mentioned, there is a big variability. What about the investigation? There are also a big variability, okay? Even in young or children and in adults, they are not the same. So I think one of the golden target is to give the patient even calcitonin. But when there is a big doubt, not any patient to give calcitonin.
Okay, thank you, Dr. Ahmed. Dr. Huda,
Yes, Doctor. Now we are, thank you, Dr. Ahmed, for this interesting, actually amazing lecture. We are moving to our next speaker, Dr. Richard Quinton. Dr. Richard is one of the IMDO family. He is well-known consultant and senior lecturer in endocrinology at the Royal Victoria Infirmary, University of Newcastle upon Tyne. He's also the regional specialty advisor for the UK Northern Deanery. Dr. Richard was awarded the prestigious Ralph Knopfler Prize by the University of Cambridge for his thesis on hypogonadotrophic hypogonadism, which remains his primary area of research interest. He talked today about the cardiovascular safety of testosterone treatment, results of UK individual patient and aggregated data meta-analysis, and also USA prospective randomized control trial. Dr. Richards, the floor is yours.
sorry, there is just technical issue. He will link for a while. It will take just 2 minutes.
Okay.
Okay.
I'm interested to hear his lecture because, as we know, testosterone is now regarded one of the androgenic hormones that's used by several people. So I'm sure it will be one of the amazing lectures.
Good morning. I'm sorry to be late.
No, no problem. It was our technical problem as well. Thank you.
Thank you. So I will now share. It's a pleasure to be back speaking at IMDO, and I do hope to meet you again all in person next year. So I'm going to share some data that I think are interesting in relation to testosterone and cardiovascular disease. So this should be the full screen. Okay. We in the UK guidelines for testosterone replacement published a couple of years ago, we said that actually there was some certainty about testosterone and cardiovascular disease. As you know, some years ago, the American FDA put a warning on testosterone for cardiovascular disease and stroke risk. One of the difficulties in this area is that you can't do studies on men with actual hypogonadism. You can't take a man with Klinefelter or with Kalman's or with hypopituitarism and randomize them ethically to no testosterone. So really what you're studying in these large studies is men that I wouldn't necessarily consider to be hypogonadal in the first place. Generally older men with obesity, often with type 2 diabetes, with normal LH and FSH and a slightly low testosterone level. So this is the thing to keep in the background. So the men in these studies don't necessarily correspond to what you might actually be treating in real life with testosterone, but it's all we can do in terms of randomization. And there are two studies published recently that I'm going to go into, one of which I was involved in, and one of which is a recently published US study. I'm going to slightly wave the flag for the UK study, which cost £500,000 compared to the US study, which cost $30 million, and they broadly came to very similar conclusions. So I'm slightly reminded of the stories. It's not actually quite true that the Americans are supposed to have developed, spent millions of dollars developing a pen that could write in space, whereas Russian cosmonauts could just use the pencil. It's not actually true, but it's still quite amusing. So how safe is testosterone in male hypogonadism? In young men, we assume it's completely safe. But we know that worldwide testosterone treatments are exploding, mainly in obese men in middle age, 40 to 59 years. And we suspect that actually these prescriptions are not likely to be targeted at those most likely to benefit. And there's an enormous variation of prescribing behavior from absolutely nihilist. Well, you're an older man. I know you've got testicular failure, but forget it. To frankly irresponsible. You're a young, fit, muscly man, goes to the gym, or you're an obese man with severe comorbidities, your testosterone is slightly low, have testosterone treatment. Prescribing behavior is enormously variable. We now know that prostate safety concerns appear to be largely unfounded. But actually with cardiovascular safety or benefit, this is uncertain. There are proponents either way. There are complex effects of testosterone on cardiovascular risk factors. There are also some mirror image studies of androgen deprivation therapy, usually with prostate cancer, taking men with a normal testosterone to start with, and then shutting it down and seeing what happens to their risk factors. There have also been cross-sectional studies, some of which show reduced cardiovascular risk, some show an increased cardiovascular risk, or no change in cardiovascular risk. And so some examples of how it could go either way in terms of the surrogate markers. We know that testosterone causes direct coronary vasodilation, which is a non-genomic effect, and it seems to be anti-anginal. We also know from the T trials that it seems to promote calcified coronary atheromatous plaques. We know that it increases muscle mass, reduces fat mass, thereby reduces insulin resistance and probably the risk of type 2 diabetes. On the other hand, it also reduces HDL cholesterol. The increases in red cell mass from testosterone promote exercise capacity and increase VO2 max. On the other hand, testosterone-induced erythrocytosis may predispose to the risk of arterial and venous thrombosis. We just simply know that from population studies where men with the highest hematocrit in general populations in Tromsø and Copenhagen had higher risks of spontaneous and and precipitated venous thrombosis and also cardiovascular events. And hence existing guidelines, such as the UK ones, have really conveyed uncertainty regarding cardiovascular risk. Let's look at the mirror image studies where it's actually been androgen deprivation. And we know this reduces lean mass and increases fat mass within 3 months. And this is mainly a subcutaneous fat that's lost, which is that's gained, which is interesting because actually that's not quite what happens in metabolic syndrome. Metabolic syndrome, you gain visceral mass, but certainly androgen deprivation studies with prostate cancer or GnRH analogs, interesting, it's generally subcutaneous fat that's lost, so it's not quite a complete model. We know that if resistance exercise helps fatigue, fitness, quality of life, but doesn't improve body composition. We know that you increase, you improve insulin resistance, but again, it's uncertain with that body composition and their effects on cholesterol, LDL-C, and increasing risk of type 2 diabetes. If we look at the hazard ratios of all the studies, look at androgen deprivation, it looks to be worse in terms of actual and surrogate cardiovascular risk markers. So this is the TOM trial, which caused large scares, showing it had to be stopped early. We can see here that here the cardiovascular events, testosterone compared with the placebo were increased, and this was stopped early after 9 months. The only problem is that even though the safety board terminated these studies, some of these cardiovascular events weren't actually things that I would necessarily take seriously, like feeling dizzy or edema. I'm not sure that these are reasons to actually terminate a study early. And so that's a shame. That study, had it continued for longer, might have given us some better information. It's published in England Journal. It caused lots of scares, and it's why the FDA then put the scare thing on the testosterone label. So in the UK, my colleague Dr. Chanajaya Sena led with the TESTES consortium, and this was individual patient data meta-analysis of all existing RCTs of testosterone, and essentially published in Lancet last year. We found no short-term rise in deaths, heart attacks, or stroke. And there were some spin-off studies for this, a qualitative analysis and also an economic analysis, both of these published these years. Overall, potentially 3,000 men, 17 clinical trials across 11 countries. So why would you do an individual patient data meta-analysis as opposed to conventional meta-analysis? Well, first of all, by drilling down into the individual patient data supplied by the investigators, you have an independent confirmation data quality. The other thing is that most adverse events don't appear in the published articles, and therefore you would not find them in a conventional meta-analysis. And also IPD allows you to then drill down to look at different subgroups, things like older men, smokers, men with diabetes, or men whose baseline T levels were equivocal. So for TESTES inclusion criteria, any RCT with testosterone treatment, there had to be a placebo comparator, there had to be adult men, and serum testosterone less than 12 nanomole per liter. We excluded crossover designs, treatment over less than 3 months. If there was a combined intervention, such as testosterone plus lifestyle stuff, as happened in the T4DM study. Also studies restricted conditions to specific conditions, such as cancer, HIV, cirrhosis, type 1 diabetes, things that could specifically affect cardiovascular safety independently. And finally, studies restricted men with syndromic hypogonadism, such as Klinefelters. So the outcomes, primary outcome was we look at all-cause mortality and cardiovascular and or cerebrovascular events. And the secondary outcomes, sexual function, quality of life, physiological markers, hemoglobin, hematocrit, testosterone levels, lipids, glucose, HbA1c, blood pressure, and other things like prostate or diabetes events. For serial measurements, we use the one closest to 12 months. And all adverse events are categorized by 2 investigators, myself and Chanajaya Sena, blinded to the intervention. So we managed to get individual patient data from 17 of 35 eligible trials. Why did we not get all the trials? Well, a large part of it was due to pharma lawyers citing data protection, hiding behind that, which is a shame. But other things that we couldn't get around, the chief executive data died, there's a corrupted hard drive, data loss. But anyhow, we got 62% of all men who've ever been enrolled in a testosterone RCT, nearly 3,500 men of nearly 5,500 men possible. Treatment duration, mean 9.5 months, range 3 to 36 months. And participants were generally older, they were overweight or obese, about over a quarter had diabetes, over a quarter already had angina, plenty of them were smokers, 8% had a previous MI. So we're looking at individuals who had not a bad, well, should we say, who already had a pretty bad cardiovascular risk at baseline. However, none of the trials individually had cardiovascular or cerebrovascular primary endpoints. So this is the headline slide. Look at all-cause mortality, and you look at the figures, there's nothing there. So of 14 studies, 8 reported no deaths and 6 reported deaths. And for the remaining 3 studies of the 17, we were actually unable to confirm whether any deaths had occurred, and so they weren't included. We can see of 1,600 men on testosterone, there were 6 deaths. 1,500 men on placebo, there were 12 deaths, and this was non-significant. And if you look at the cardiovascular events there, they're all a kind of random hodgepodge there. If we drill down into cardiovascular and or cerebrovascular events, let me just pull this down here. Pull that down here. We can see in 13 studies, 120 over 1,600 men on testosterone had a cardiovascular event. On placebo, 110 over just over 1,500. Again, completely non-significant. And very small number of events, really. And again, if you look at these events, they're a hodgepodge of different things. So. Cerebrovascular events, again, virtually indistinguishable between testosterone and the placebo, and non-significant. Even if you look at even if you try and separate out the cerebrovascular and the cardiovascular, there's no signal there. Here, this is the forest plot here. These are the IPD data here, and here we aggregated the data, including the studies which would not give us individual patient data, and we can see the forest plot in each case crosses the zero effect point. Now look at physiological markers. Sure, obviously the serum testosterone was higher, free testosterone was higher, hemoglobin was high, hematocrit was high. This is just what you expect to see by giving testosterone. Looking at the lipids, we don't really see any effect here apart from, as you know, the expected reduction in HDL-C. Fasting glucose, not really, and HbA1c, not really significant whether or not you've got diabetes or had diabetes baseline. Systolic and diastolic blood pressure, no real effect. Okay, so other outcomes, maybe slightly fewer new diabetes diagnosis or diabetes complications, but again, non-significant on testosterone. The prostate cancer signal was not significant in the 8 studies. Edema, yes, that is seen on testosterone treatment. High hematocrit, yes, that is seen as a complication on testosterone treatment, which is not really surprising. But in terms of hypertension, venous thromboembolism, non-stroke cerebrovascular pathology, no signal there really. So limitations of testes. So we only had independent patient data on 60% of participants, but nevertheless, this was concordant with the aggregate analysis. The trial, none of the trials used a unifying major adverse cardiovascular event classification. because actually there wasn't a unified definition at the time. So Dr. Chan, as I was saying, had to decide what we thought was significant and what wasn't. There's also a very low number of recorded deaths, and the mean follow-up was only for 9.5 months, although some were followed up for 36 months. So our key findings would be that few deaths have occurred during testosterone treatment. There's no current evidence that testosterone treatment for less than 1 year increases the cardiac or cerebrovascular risk, even in men with a high baseline risk. Of course, these men were generally men, again, I would call them maybe slightly fat men with slightly low testosterone, not the kind of like full-on hypogonadal men that we necessarily treat in general in clinical practice. We didn't identify actually any high-risk subgroups. We found no effect on glycemia or blood pressure. We saw the known effects on hematocrit, edema, and HDLC. Certainly, although we're far more relaxed about testosterone and cardiovascular disease for men with non-organic hypogonadism, the longer-term safety data remains uncertain. So let's see if our American colleagues did any better with their $13 million. This is the Traverse study, published in New England Journal. Similar inclusions are excluded to us. This was an RC. This was a prospective RCT. So they were generating new data rather than looking at past data. The inclusion was similar to ours, for testes, established cardiovascular disease or at high risk of cardiovascular disease, at least one hypogonadal symptom, and 2 serum testosterone levels less than 10.4 nanomole per liter, slightly lower than our threshold. This was fasted 9 a.m. They excluded severe hypogonadism, which they said was serum T less than 3.5. Anyone who'd had a very, very recent cardiovascular event or procedure within 4 months. Anyone who had testosterone treatment less than 6 months ago, known thrombophilia, uncontrolled heart failure, or who was known to have prostate cancer, a high PSA, or a suspicious prostate nodule. And so they came out with more than just over 5,000 men, which is very similar to what our target would have been in testes had we been able to get IPD from all studies. And this used testosterone gel versus placebo for up to 4 years, and with a medium serum testosterone at 7.8 nanomole per liter. The similar aged men to those that we picked up in the testes, but weighing more. Well, of course, they're Americans, and a greater prevalence of established cardiovascular disease, diabetes, hypertension, dyslipidemia, more smokers, CKD. So these men were in a significantly worse condition in terms of cardiovascular status than was the case in testes. And so here are their data. This is the testosterone level in American units versus placebo. What's actually interesting is that we can see that as you get closer to the 4-year mark, the error bars begin to overlap much more. And one reason for this is simply the dropout was very high in this study, surprisingly high dropout. Very few men actually got to the full 4 years. And also maybe some mission fatigue. So men getting slightly more bored, slightly more slapdash with applying their testosterone gel over time, which again gives you some idea of whether they thought they were getting much benefit from it. So primary outcome, major adverse cardiovascular events, MACEs, cardiovascular death, non-fatal MI, non-fatal stroke. And the trial was powered to stop once they'd got to more than 256 events. And these lines are virtually superimposed on each other. There is just simply no effect of testosterone versus placebo on MACE risk. And if you break this down into the individual MACE components, cardiovascular death, non-fatal stroke, non-fatal MI, again, the lines are virtually superimposed. So limitations, the mean treatment duration was 21 months for both testosterone and placebo. So although this went on for longer than, captured data for longer than testes, it was still less than 2 years. The mean follow-up was 33 months. So even men who fell out of treatment before then, not many of them got to the 4-year mark. Similar dropout rates of 61% of testosterone and placebo. Again, there's a perception that if the rate's that high, then these men are probably not perceiving much benefit. So again, to summarize, very few deaths have occurred during trials of testosterone treatment. There is no current evidence that it elevates cardiovascular risk for a period of up to 2 years treatment. There are no high-risk subgroups identified for cardiovascular events on testosterone treatment. There's no effect of testosterone on glycemia, and that's in real life and without lifestyle. We know that there was a major effect on glycemia in the T4DM study, but that was a combination of testosterone treatment and lifestyle. No effect of testosterone on blood pressure. There are known effects on hematocrit edema and HDL-C. And we can consider whether the long-term safety of testosterone treatment merits further consideration. I can go on to talk a little bit about testosterone for sexual symptoms, or would you like me to end here and have a and start the discussion now, depending on how time's going? So can I ask the chair whether you'd like me just to end now at this natural pause, or whether you'd like me to do a little bit about testosterone and sexual symptoms in a few more slides? Chairman?
You have more time, Dr. Richards. You
Okay.
have a few minutes. Thank you.
That's fine, no problem. Okay, so we know that for sexual symptoms, there's a clear benefit for younger men with organic hypogonadism. But again, remembering most testosterone is worldwide prescribed for men more than 50 years old and with high BMI and without organic hypogonadism. And again, there's a very, very wide variation in prescribing behavior. So we know there's some evidence from the T trials that testosterone does improve sexual function in older men, but there's an evidence gap whether the effects attenuate with increasing age. We know that testosterone increases sexual function in men with obesity to some extent, but does obesity attenuate that effect compared to in lean men? We know that testosterone can improve sexual function in men with various pre-treatment testosterone levels, but is the benefit greater with more severe baseline deficiency in testosterone? This, for instance, is data from an RCT by Shailendra Basim, JCM last year. And really, we can see that in unfit men, testosterone modestly improves sexual function, and the effect seems to be sustained for at least a year. Although, as we see, when you get to 2 years, the error bars begin to overlap compared to placebo. And so we took the same data or the same studies in the testes that we used to look at cardiovascular risk, and we tried to see, in terms of sexual symptoms identified in these studies, whether there were any subgroups where actually the improvement was more marked or less marked in others. So by sexual function, we took the IISF-15 score. There were nearly 1,500 patients across all the testes studies in which this had been measured across 5 studies. And we could see that the score was improved significantly in testosterone compared with placebo. This was a composite of a number of different things. If you looked at the different bits and pieces individually, erectile function, orgasmic function, sex desire, intercourse satisfaction, and overall satisfaction, none of these showed up anything much, but the composite score showed up a signal. And let's see overall whether it made a difference whether you were older or had diabetes, or were a smoker. Really not much there except that if you're a smoker, that was the only thing that signaled that maybe you had that you probably had less benefit. Other issues didn't seem to affect, not even testosterone levels seemed to affect whether you experienced benefit or not. So limitations, individual data not available from all studies, but it was concordant with the aggregate data, different dosing regimens, different patient-reported outcome measures, and probably that IEF 15 score probably underestimates effects on sexual function. And of course, across these studies, not all men had civil relationships. Men were like having their partners were dying, they were getting divorced, relationships were breaking up. So that can make an enormous difference to sexual function, whether or not you have a partner and whether that's going well. In summary, testosterone treatment for the symptoms of low testosterone, yeah, there's undoubted benefit for men with organic hypergonadism. Other men, yes, there's some data for improved sexual function and quality of life versus placebo, although again, beyond 2 years, the effects are uncertain. And these improvements are not going to be associated with age or BMI or pre-treatment testosterone levels, testosterone formulation, or diabetes status. So it may be that this effect is pharmacological rather than endocrine, and you really need a larger sample size to pick them up. And the impression is testosterone has efficacy in all men with low testosterone, but in men who are older or obese or have low testosterone levels, there'll be more residual symptoms. So if you're starting off for a really bad baseline in terms of sexual function, testosterone may improve things, but actually, if your baseline is that bad and you improve a bit, that improvement is not necessarily going to be significant for you functionally. And really, we go back to the fact that lifestyle change remains what I would call the gold standard or Rolls-Royce treatment for obese men. So thank you very much for listening. I'm sorry about the confusion and the delay initially. And I'm very happy to take any questions.
Thank you, Richard. Thank you, Dr. Richard. Actually, I'm interested in having the same topic by 2 studies in UK and US. So why they have to repeat the same study? Meta-analysis, we know it's just reviewing a formal studies. So which one you think it is more have more accepted finding? And I know they only focus on testosterone. They do not talk about the brands they use, if they use a renal friendly product, the different protocols. Which one of these of the 2 studies you think we can make a protocol for using testosterone upon their results? Which one of them?
Well, of course, a randomized controlled trial is the gold standard if you can get it to completion. However, we knew that the testes we knew that the American Traverse study was in progress, that it had funding. What we didn't know was would they actually get to completion. Particularly as we were hearing that these dropout rates were very high. We believed that we could get out data, very useful data, to doctors earlier in terms of cardiovascular risk. So in a sense, the TESTES study put out reassuring data to doctors and patients worldwide 18 months before the Traverse was published, and obviously the cost was relatively minor, £500,000. So had the Traverse already run, there would have been no reason to do the testes study. But we felt it was important to get data into the public domain as soon as possible, and I think as a proof of principle, this just shows how using existing big data can give you really important information by pulling it all together. Now, had the Traverse study been designed with the knowledge of testes, would it have been worth spending $30 million on it? I don't think so. I don't think so. Particularly with, I think if you were going to do it, you'd want to make really sure that you were getting men staying in the study for longer. You know, not just almost all of them dropping out after 1 year. But of course, this was COVID as well, and so that may have influenced the relationship between the investigators and the volunteers. But overall, both those studies show the same thing, that in men at high cardiovascular risk who haven't really got proper hypogonadism, testosterone is safe. The Traverse study actually showed confirmed there was no prostate cancer. There was no prostate cancer signal. But is it worth it for the sexual symptoms? Improvements, maybe, certainly for up to a year, maybe not for over 2 years. One concern actually is that the Traverse have published fracture data, and what they're showing is that, contrary to the effect you see in men with organic hypogonadism, that men with should we say fat men with slightly low testosterone, that in the Traverse study, the testosterone arm had a higher rate of fracture. Just published recently in New England Journal, which is somewhat concerning. Maybe they were more active. They didn't get bone density data, so they left a little bit of a mess there.
I think similar study can be used as a base for clinical trials. You know, they can even repeat the similar test, a similar study, but focus on the genetic background of the patient, because maybe those patients who have developing the cardiovascular complication or even prostatic cancer, they maybe have already genetic or epigenetic risk not related to the testosterone. They may develop the disease because by other mechanism. So
well, yeah, no, I agree, certainly, and certainly in our the UK guidance on testosterone, one of the things we said about prostate cancer is that the really important things to consider in terms of risk factors, if you have a family history, or if you're from Black African or origin, then your risks of prostate cancer are much higher, and these men need looking at more carefully. But overall, we could see no reason why men on testosterone should be screened any differently to the general population. We know the US has a prostate cancer screening program. The UK doesn't. But of course, even the Traverse study in terms of prostate cancer, you know, things change as studies go along. So one of the things that's really revolutionized prostate cancer management and risk management over the last 5 years or so is prostate MRI. So in the past, at a high PSA, men were ending up having lots of like prostate biopsies, painful procedures, missed targets, or borderline results. Now with prostate MRI, you can say, yep, you got a nodule, we'll biopsy that, or no, you haven't got a nodule, we're not concerned. And so even the Traverse, a really up-to-date study, because it was in the way it was designed, the design started about 10 years ago. They didn't factor in how MRI would revolutionize risk stratification in prostate cancer risk.
Thank you very much, Dr. Richards, and I hope we see you here in Bahrain next time. Thank you very much.
Dr. Huda, it's a great pleasure to see you again, and I see some colleagues I remember from the past, and particularly Dr. Assad. And if I can just say to you as well, I hope that some of you will come to Clinical Update in Birmingham, and I also hope that some of you will come to a Clinical Reproduction Update, which is a new thing for the Society of Endocrinology, which Dr. Chana Jasser and I will be running in Birmingham on the 4th of December, 2024. And this will be a one-day devoted to reproductive endocrinology issues and questions, and details on the Society for Endocrinology website. All the
We're happy
best.
to be there. Thank you very much, Doctor. Thank you very much.
Thank you. Bye.
Now we are moved for our next speaker. I am proud to present Dr. Salam Jibril. Dr. Salam is a highly accomplished senior consultant in obstetric and gynecology. He is specializing in IVF. With his experience in reproductive medicine, he has helped numerous couples achieving their dream of parenthood. Dr. Jibril is highly well known in his medical field and has dedication to provide the highest standard of care. Today, he will talk about a challenging subject, which is the premature ovarian failure, a new hope for the new patient. Without any further ado, Dr. Salam, the floor is yours. Thank you.
Thank you, Dr. Ahuda. Thank you for the introduction. It is a pleasure to talk about a tough subject like this one. Let me share my slide with you. This. Actually, I have chosen this topic because premature ovarian failure cases are the most frustrating to the gynecologist. I haven't seen a frustrating situation more than the premature ovarian failure, except the breast cancer patient to tell her the news that she is having a premature ovarian failure and the other one to have a breast cancer. These two situations are very frustrating. What to tell the patients and how to approach the patient. And on reality, the situation with the premature ovarian failure is not as bad as everybody thinks. It's not only giving hormone replacement therapy. I will go through these minutes talking about the history, the definition, the causes, the epidemiology, the mechanism and the clinical presentation, and how stem cell future treatment will help in premature ovarian failure, and how male partners are different from the female in such premature ovarian failure. And of course, I will touch quickly on some aspects of the treatment. And the reason I have chosen this, because those patients who have premature ovarian failure, if we identify them earlier, we can do what's called fertility preservation for them, keeping some of the ovarian tissue before it fades away. And identifying those patients is very helpful. The same help we are giving to those cases of malignancy. Before they start their treatment, we can do fertility preservation in their ovaries, especially ovarian tissue cryopreservation. And in the history, Paul Albright in 1942 was the first one to describe a syndrome of amenorrhea, estrogen deficiency, and menopausal FSH level, and short stature. And this is his report written in the in the medical literature.
Dr. Salam, Afwan, sorry to interrupt, but can you start your presentation and just scroll down? We only have the first page, the introduction, the title.
Only the title?
Yes, yes, yes.
Okay.
Please just scroll down your slides.
Is it okay now, Dr. Iman?
Yes, it's okay.
Yes, doctor.
Okay, so the first report was from Fuller Albright, but there is in the Chinese history, in the Qin dynasty, they have mentioned something like the premature ovarian failure description, which was glosses as not yet old, menstrual water cut off. And that's in the Chinese medical history. But the first case report about the premature ovarian failure was by Morris and Rohanson in 1967. And the first hormone profile case described was the hypergonadotrophic hypoestrogenism in 1939. In 1950, clinical features of premature ovarian failure were discussed by Atria, and the author have reported 20 young women before the age of 35 having the premature ovarian failure symptoms like hot flushes, infertility, endometrial atrophy, and so on. So there are many names given to the same identity, premature ovarian failure or premature ovarian insufficiency or premature menopause. And this usually affects 1 in 10,000 under the age of 20 and 1% under the age of 40. But the triad that describes this is the amenorrhea, hypergonadotrophism, and hypoestrogenism. And of course, patients will come with different presentation. The most notorious and well-known is the hot flushes, night sweats. And those patients are having all the symptoms of withdrawal of estrogen, like the vaginal dryness, skin changes, and the dryness actually. And of course, they are irritable, depressed, anxious, and all these symptoms which are known to us in their first presentation. And the hot flushes are the most common symptoms usually when the patients approach the 40s. And the vaginal dryness as well is the most common symptomatology for all age groups. And of course, the premature ovarian failure is a heterogeneous group. 90% of the cases, we don't know why they develop such a thing. And of course, it has a genetic cause, autoimmune, enzymatic deficiency, infections, and other factors like the environmental factor and radiation. And 2 to 5% of those women have a pre-mutation of the FMR1 genetic abnormality. And this has a risk for what's called the Fragile X syndrome. So the major cause of premature ovarian failure include autoimmunity, genetic, and environmental factors. And these factors differ. And before the age of 25, the incidence of the prevalence of the premature ovarian failure is 1 in 10,000. But before the age of 40, it's 1%. And the occurrence worldwide is 3.7%. And in the United States, it's 1% in the white women, and it's more common than the white in the black woman, 1.4%. And in the Far East, the Japanese are having less prevalence, and the Chinese as well. And in 15% of the cases, there is a familial occurrence suggesting a genetic etiology background. So when we are diagnosing a patient with premature ovarian failure, we should always check their beta HCG to exclude pregnancy, because most of their presentation is with amenorrhea. And we have to check FSH and estradiol, also to check the anti-Mullerian hormone, to do karyotyping to exclude the Fragile X syndrome, and of course the Turner syndrome, and to check on thyroid, and especially check on thyroid antibodies. Hashimoto, I have one case of Hashimoto who presented to me as premature ovarian failure, and she was given only treatment for premature ovarian failure. She came and we did for her IVF, and we could retrieve 2 eggs from her, and we transferred the 2 eggs after being fertilized, after preparing her, and she conceived with 1 child. Unfortunately, after that, she tried again and again, and she wasn't successful. But it's important not to classify those premature ovarian failures as having no chance of conceiving. Of course, transvaginal ultrasound is important to evaluate the number of follicles, the number of eggs still seen in the ovarian tissue. And of course, DEXA is very important to know, to assess the bone density of those patients. And as I said, there are multiple factors. Autoimmunity is one of these factors. Aging process is important as well. And apoptosis of other cells in the ovary and DNA damage induce follicular apoptosis. And this is a summary of a difference between healthy and premature ovarian failure. And as we said, apoptosis, autoimmunity, and aging and angiogenesis are the contributing factors of all those changes leading to premature ovarian failure. So what's the clinical presentation of those patients? Differs. It can be with menstrual abnormalities. Usually patients come with primary amenorrhea to us in the fertility or subfertility presentation. Menopausal symptoms like the hot flushes, vaginal dryness, insomnia, and others. Of course, if they have some autoimmune disease like the vitiligo or hyperpigmentation, adrenal insufficiency, they can present to us with premature ovarian failure, also with thyroid symptomatology, and sometimes only with psychiatric presentation. So the premature ovarian failure can be spontaneous and can be induced. Induced is when we inflict this on the patient. But the spontaneous majority of those cases are idiopathic. But still genetic, we have, as I said before, we have to check their chromosomes to make sure that their karyotyping is normal, especially the Turner's and the Fragile X syndrome. There are other syndromes which we have to check on. Now, with the presence of, with the whole exome sequencing, we can go and into more details of the genetic constitution of those patients. One thing of importance I want to mention is the infections. Mumps oophorytis is something which we thought before that it will not lead to a premature ovarian failure as it is. Other infections, of course, are very important, especially the HIV and the other infections like tuberculosis and the other type of viruses. Of course, the induced one is mainly because of the chemotherapy and radiation treatment. The environmental one is also of value, and the vessel embolization, pelvic vessels embolization, can lead to premature ovarian failure. The chemotherapy with the advanced treatment of malignancies, we are seeing more and more of the premature ovarian failures. And there are different types of, especially the alkylating agents. And we always advise those patients who want to have chemotherapy to come and have their ovarian tissue or their eggs frozen so that they can preserve their fertility, because those chemotherapy medications will definitely inflict negatively on the ovarian reserve. Also, those who are subjected to radiotherapy, they are going to have loss of the ovarian reserve, and it depends on the amount of radiotherapy they are exposed to. Again, the autoimmune disorders, we should emphasize on the autoimmune oophorytis, Hashimoto thyroiditis, Addison disease, and type 1 diabetes, and pernicious anemia. These are the autoimmune diseases which we should always remember. In the genetic, as I said before, Turner's, Fragile X syndrome, and metabolic and enzymatic defect. One study showed a strong correlation between the incidence of premature ovarian failure and certain variants in the inhibin alpha gene. And that's why those patients should have more investigations than just simple FSH and LH and estradiol. We have to look more into other investigations to see what type of premature ovarian failure they are having. Of course, this is from a study in West London menopause group, and the idiopathic is the majority of the cases, followed by the malignancy. I just want to mention here about the chemotherapy and the radiation. They are a major cause of premature ovarian failure. Cyclophosphamide, for example, 87% reduction in primordial follicles within 72 hours of the use of the cyclophosphamide. Patients who are subjected to hysterectomy, they have double-fold increase in risk of premature ovarian failure. That's due to the vasculature influence on the ovaries. Pelvic surgery as well, it can increase the chance of premature ovarian failure, especially in the cases of ovarian cyst and endometriosis, if we have some damage to the ovarian blood supply. Toxins as well, these chemicals are very important to avoid because they can lead to the premature ovarian failure. This is in summary the radiations and the chemicals. which are included in the food packing, iatrogenic from our extra radiation, also by radioactive substances, some chemicals, some medicines, and all these will affect the ovary and cause premature ovarian failure. The genetic association, there are many genes which are related to premature ovarian failure. It's mentioned here the different types of genes that are related to premature ovarian failure. Of course, diagnosis should be based on age. It should be less than 40, amenorrhea, and 2 elevated serum FSH estimation and decreased estrogen 1 month apart, and anterior pituitary is the one responsible for the secretion of the FSH and LH. Both will be high. And of course, typically the FSH should be over 40 micro international units per milliliter. Not to forget the effect of the genetic, the karyotyping, again, to remember the Turner syndrome and the fragile X. And of course, we should do the pregnancy test, prolactin, to estimate the prolactin and the TSH. The initial assessment of the patient should include FSH and LH, estradiol, thyroid function and prolactin, antithyroid, anti-adrenal, anti-ovarian antibodies should be studied. The genetic, the karyotyping, the ultrasound, as I said, the DEXA to estimate, and the anti-Mullerian hormone and inhibin B to assess the ovarian reserve of those patients. This is from the NHS in London, the data to collect from those cases of premature ovarian failure to see if they have any.
So, Salam, you have 5 minutes more.
Okay. So let's go quickly to the mechanism, how premature ovarian failure happen. There is follicular migration defect, early decrease in primordial follicles, and increased follicular death, or related altered maturation and recruitment of the primordial follicles, genetic-wise as well, and the anti-Mullerian hormone is correlated with the remaining number of follicles in the ovaries. Genetic factor, mutations, we have to check on these mutations. And the DNA repair deficiency, I'll go to the slide. This is how the DNA repair deficiency happen. It's affected by the usual effect from the oogonia to primary oocyte to primordial follicles to give us finally a normal, healthy egg. The deficiency in the DNA is the major factor. Treatment, we focus mainly on 2 things. On HRT to keep the patient in good health, and the fertility concern, how we can keep the fertility of our patients by having ovarian cortex preservation, by freezing of the oocytes and the embryo, and the other methods are the oocyte donation and the embryo donation, as well as the adoption for their fertility. These are the different modalities of treatment, and majority of the induced cases, as I said, and the idiopathic as well. And in the treatment, the most important nowadays is the new modality, which is a stem cell dependent therapy. The others are treatment for different types in different situations and occasions. Of course, this is the new modality, which is the mesenchymal cell type of reviving or rejuvenating the ovary. And this goes through different stages, and we can revive the ovarian tissue through genetic regulation as well. This is what we do for the cryopreservation. We do laparoscopy. We take pieces, fragments of the ovarian cortex, and freeze them. Later on, we can do transfer them back. We do autograph, and then we can use these and make IVF for the patients. This is the effect of the epigenetic modification on the oocyte itself, DNA methylation, microRNA, and histones modifications as well. This is the mesenchymal stem cell. I will just mention that we go to proliferation of new follicles using the mesenchymal stem cell. And with these mesenchymal cells, we revive the ovary and produce new follicles to be used for fertilization. We, of course, tissue inflammation and hypoxia and injury, we revive that by the mesenchymal cell and promote new cells in the ovarian bed itself. This is the mesenchymal cells. We go by immune modulation and cell-to-cell contact. And this is the mechanism we are using to stop the apoptosis and revive the follicles which are present within the ovarian tissue. Again, this is the pathophysiology, how we go through the stages to go to premature ovarian failure. And in our treatment, we focus on oxidative stress and inflammatory aging that cause premature ovarian failure, mitochondrial damage, and premature ovarian aging, telomere shortening, and DNA damage, and apoptosis of the follicles. This is the mechanism. We go through stem cell therapy for premature ovarian failure. And with this stem cell, we add to angiopoietins and signaling with different markers, and those will cause reviving of the ovarian tissue follicles. These are the different types and stages of reviving the ovarian tissue. We are looking at what is called rejuvenation of the ovarian tissue through all these steps and stages. The mesenchymal stem cell comes from bone marrow, stromal cells, adipose-derived mesenchymal stem cells, and extra-embryonic stem cells, and ovarian stem cells as well, and engineered stem cells, induced pluripotent stem cells. All these can be used in rejuvenating the ovarian tissue. And that's how they look like. These are the steps of the regeneration of the primordial germ cells, which end up having an embryonic gonadal somatic cells. And on mice, we have an embryo produced through these different stages. Do we have the same in the male premature gonadal failure? actually the spermatogonial stem cells in the adult, in the male adult is present until late years of his life. It's different now. We are trying to isolate what's called oogonial stem cells, and of course this can be extracted from the aged animals, the oogonal stem cells, and we can revive the ovary and prevent the premature ovarian failure, the same as the spermatogenesis which happen in the male. So we can preserve the oogonial stem cells again and use them for rejuvenation of the ovary. In conclusion, these findings, in addition to a large number of animal studies, have offered the opportunity for the application of oogonial stem cells as a target for premature ovarian failure therapy and restoration of ovarian function and subsequently restoration of normal fertility. Still, clinical studies are needed. We are still at the early stages of reviving the ovaries. It has been proven and as a method. In Stanford, they have produced, I think, 3 or 4 as an exceptional experimental method of rejuvenating the ovary. And in some cases, one of the cases was Fragile X syndrome case. Achieving such success will require allocation of a great deal of time and experiment as well. Until this time, early diagnosis of premature ovarian failure and cryopreservation is the best option for those patients until we, I think, in the very near future, we develop this method of rejuvenation with the mesenchymal stem cell. The Chinese are working hard on that part. And of course, mesenchymal stem cells for premature ovarian failure therapy is proposed by different modalities, but still it's on the research stages, but hopefully we will find a solution one day. Thank you.
Thank you, Dr. Salam. Thank you very much for this interesting speech. Because we are running short of time, I think I have to move to our next speaker.
Sure.
Thank you very much.
Thank you.
You don't want to answer the question, Dr. Huda? There's one question.
Okay,
Just
okay. Okay, there's one question.
Please.
From Dr. Zahra Khalifa. As she said, she came across 3 young ladies with ovarian failure at their 20s during COVID pandemic. Do you think it's related to the COVID infection or other cause? Thank you.
Anything can be related to COVID these days. Anything, because we don't know what was happening. Truly, I have COVID has interfered with the menstrual pattern in female. We have noticed that, me and Dr. Shashi, who was working with me in the early days of COVID pandemic. And we have noticed that this could also affect the ovarian reserve. I don't have a data. I don't have any study to prove that COVID has such a thing, but they could be a cause as any other viral causes like the mumps and the other viral affection of the ovarian tissue.
Okay. Thank you. Interesting. Thank you very much, Doctor.
Thank you, Doctor.
Thank you. Now we are moving for our next speaker, Dr. Najah Zayani. Dr. Najah is highly accomplished medical professional specializing in gastroenterology and hepatology. She obtained her medical degree from American University of Beirut and completed her postgrad training in the United States. Dr. Zayani has held different academic and clinical positions, including faculty roles at Baylor College of Medicine and Arabian Gulf University. Since 1986, she has been in private practice in Kingdom of Bahrain, focusing on gastroenterology and hepatology. Currently, Dr. Zayani serves as the Vice Chairman of Bahrain Specialty Hospital and Head of Gastroenterology Department. Her extensive experience and leadership role have earned her a well-deserved reputation in medical community. Dr. Zayani will talk about NASH. Can it be treated? Can it be prevented and treated? Without any further ado, Dr. Zayani, the floor is yours.
Thank you, Doctora, for the kind introduction. I thank the IMDO family for allowing me to present my personal experience with a disease that is becoming very common in our community. NASH cannot be prevented, our local experience. About 25 to 35% of adults in the West are affected by non-alcoholic fatty liver disease. And in our area, the rate is higher, estimated about 30% of adults in GCC region. As many as 68% of our diabetics in Bahrain are affected, as was demonstrated by a surveillance study. And estimated that 33% of those affected with fatty liver will eventually develop inflammation, hepatocyte injury, and fibrosis. Hepatic decompensation and cirrhosis has been shown to develop over a mean time of 7.6 years in 3% of patients who are diagnosed as non-alcoholic fatty liver disease. Because fatty liver disease is very common, this will present a major increase in the rate of cirrhosis in our community and all over the world. Hepatic steatosis is also an independent risk factor for development of hepatocellular carcinoma, and 7% of patients with non-alcoholic fatty liver disease cirrhosis will develop HCC over 10 years' time. The disease, as I said, affects 25 to 30% of the general population, more so in our area than the West. And those with fatty liver, about 25%, between 10 to 30% will develop inflammation, which is NASH, non-alcoholic steatohepatitis. And among those, 10 to 15 will develop end-stage liver cirrhosis or hepatocellular carcinoma, or will end up with a liver transplant. Now, what determines those who go into severe inflammation to cirrhosis versus those who remain with fatty liver without inflammation or develop inflammation yet do not progress to cirrhosis is highly dependent on many factors, including oxidative stress, mitochondrial dysfunction, degree of inflammation, and several other immune reactions. Gut-derived endotoxins may contribute, so our microbiome may be selectively pushing some people to faster fibrosis. The degree of fibrosis goes from stage 1, where it is minimal, to stage 2, crossing 2 areas of the liver lobule, to stage 3, where it forms more bridge of fibrosis, and into stage 4, where cirrhotic nodules are present. Can this be detected by any other method? Liver biopsy remains the gold standard for diagnosis of fibrosis, but it is invasive, expensive, and subject to sampling error. Liver biopsy is impractical to be repeated multiple times on the same patient. So people have discovered non-invasive ultrasound methods like pulse shear wave or fibroscans, MRI elastography, and these tools are becoming highly effective in detection of liver fibrosis. The stiffer the liver is, the faster is the pulse travel by ultrasound, and normal speed of travel is 1 meter per second or less. This is very easily done at the bedside, either by transient elastography, or our preferred method in our clinic is pulse shear wave measurement, which is less operator dependent and allows us to sample bigger areas of the liver. It's also live. You can see the area of the liver you are sampling. MR elastography is also emerging as a tool for diagnosis of liver fibrosis. Is there validation that liver non-invasive tests correlate with cirrhosis? There is this interesting study published in 2012, which shows in people with viral hepatitis, there is a good correlation with significant fibrosis appearing after a score of 1.55 meter per second and cirrhosis at 1.8. What's the story with NASH? How accurate is this measurement in NASH? We looked at a study in our population where we actually looked at liver biopsy correlation with shear wave scan, and we were able to assess patients with this condition. In 54 patients, we were able to correlate the shear wave score, which was done in the same week, with the reading of the histopathology, while the pathologist was blinded to the score, and we could draw the correlation between accuracy of detection of fibrosis based on this sample of patients. The diagnostic accuracy was 83% for sensitivity and 80% specificity, with a total diagnostic accuracy of 81%. And when the score was above 2.8 meter per second, it predicted advanced fibrosis score, and when it was less than 1, it predicted no fibrosis. So this is the plot of our sample. And therefore, when we meet patients with diagnosis of fatty liver, we always screen for NASH. And based on this data, as well as data from literature, we were able to follow 419 patients in the years between 2016 and 2023. And we were able to offer them treatment for obesity, which is the major factor associated with NASH, and also correct their metabolic diseases. So among them, the 419 patients, 392 cases were compensated NASH, and 27 presented at a stage of decompensation, manifested by ascites, jaundice, encephalopathy, variceal bleeding, low albumin, coagulopathy, or hepatocellular carcinoma. The aim of the study was to evaluate the clinical course and effect of treatment on their liver condition. The ultrasound findings are very interesting, and I learned a lot from looking at these patients. Ultrasound can be done at bedside. It's easy, it's cheap, it can be repeated to follow up patients. As soon as you detect increased echogenicity of the liver comparable to the right kidney, you know that this patient has fatty liver. Therefore, you can estimate the size of the liver, the morphology of the liver, and you can get information about whether the liver is clearly demarcated or has a scalloped edge suggestive of cirrhosis. You can also look for ascites, dilated portal vein, splenomegaly, the presence of varices, or hepatocellular carcinoma. The more you do of these cases, the more you will detect fibrosis. When advanced fibrosis occurs, there is loss of fat, and therefore it can be misleading to the examiner. The liver will shrink in size and lose the echogenicity because of the fibrosis. Therefore, you can resort to shear wave measurement to estimate the degree of fibrosis when you suspect it. There are newer modalities on the market, like fat fraction by ultrasound or MRI, where you can actually calculate the degree of fatty infiltration. And I can say we are lucky enough to have this modality in our clinic. So the total number of cases encountered, 419, majority were in compensated state, 392, and 27 of them were in decompensated cirrhosis. The male-female ratio is predominantly female, possibly bias of referral, but this disease affects both males and females and can manifest in our society more so in females because of the rate of obesity and the fact that most women here have a very sedentary lifestyle. Decompensated were, again, majority were females, again, reflecting the same sample data. So in all of these cases, the management was, first of all, to educate the patient to the fact that you do have this condition, that your shear wave score indicates fibrosis, And therefore, would you be interested in treating this condition? Data on age, gender, weight, BMI, and abdominal girth was reported. Associated medical illnesses as diabetes, hypertension, cardiovascular disease were reported. Patients with any other cause of liver disease like viral, alcoholic, or autoimmune were excluded. Patients were started on a low-carb diet under supervision of dietitian and offered screening for their cardiovascular disease as well. And hyperlipidemia as well as diabetes and hypertension were treated. If the patients in decompensation had enough liver reserve, they were offered the same diet. Between 2020 and 2023, when GLP agonists became available, some patients were started on GLP agonists, and I'll show you the breakdown of these numbers. The patients were also advised moderate exercise and clinical follow-up with the dietitian every 2 weeks to assess their diet progress was given for free. Clinical follow-up by the physician every 6 weeks, and the monitoring of their shear wave measurement was done after 20 weeks and 52 weeks of diet. This is the presenting symptom of patients. Most of them presented with high abdominal girth. 61% of them had elevated liver enzymes, and about half of them had diabetes at time of presentation. As I said, the abdominal girth should be the first alerting sign to this condition. The number of NASH cases encountered, not all of them agreed to go on diet. 41 patients refused to go on diet, and they said, we just will not follow, we're not interested, in spite of explanation. Among the 378 consulted, only 228 at the end of the study of 1 year were compliant to diet, and 70 of them started off with the diet but did not keep it, and 79 refused to come back for follow-up, stated they did not follow the diet or they were not interested. Among those who were followed, 33 cases were referred to surgery, bariatric surgery, either due to failure to lose the weight or because of morbid obesity, and patient agreed to go for bariatric surgery. So 169 ended up with diet alone, and 26 patients ended up with diet and GLP agonists. This is a breakdown of the shear wave score of these compensated cases. As you will see, majority of cases fall into the severe degree of moderate to severe degree of fibrosis between F2 and F3 fibrosis. Decompensated cases presented with these findings: ascites, low platelets, gastric or esophageal varices, high bilirubin, low albumin, or the presence of hepatocellular carcinoma. Now, these people did not do very well. As you can see, 4 ended up with transplants, and 4 are awaiting transplants, and 2 developed hepatocellular carcinoma. As this is reflected in the literature as well, these people don't do very well. Their survival is compensated tremendously, and we should list them for liver transplant once we recognize their liver failure. The compensated weight loss profile after 1 year of diet in those who are compliant to dietary restriction, the results were dramatically better than those who were non-compliant, and those who were totally non-compliant gained weight at the end of 1 year, on average about 3 kilos. In the decompensated group, the weight loss was even less noticeable because they were affected by other illnesses like cardiovascular disease, and exercise was less than optimal. If we compare people who are compliant to diet versus those who did not comply completely to diet, the results of drop in shear wave is dramatically different, indicating that weight loss and associated drop in shear wave was evident in the compliant group. The outcome of average weight loss and shear wave drop among the 3 groups, which were diet only, bariatric surgery, or diet plus Ozempic, indicate that bariatric surgery is the most effective strategy in drop in weight, and it leads to improvement in the shear wave of the patients, indicating improvement in their stage of fibrosis. Those who received Ozempic in addition to the diet also lost on average 12.6 kilos, and their shear weight also dropped. Those who followed diet alone lost on average 7.9 kilos and had a drop in their shear weight. If we look at the liver is affected by fatty changes due to insulin resistance. There's a lot of triglyceride synthesis in this liver, and this triglyceride accumulation in the form of fat leads to cascade of inflammation, liver toxicity from fat, and then several other factors enter, including the gut interaction with the liver and proliferation of the stellate cell, which lead to fibrosis. So the new drug therapy is going to concentrate on mechanisms of inflammation. And I want to point out to you that one of the major players in the field is the thyroid receptors on the liver, which play a vital role in getting rid of fat in the liver and blocking the cascade of inflammation. What drugs are available for NASH? Presently, vitamin E is offered, however, increased risk of hemorrhagic stroke and prostate cancer, limits its utility in this diagnosis. The glitazones are associated with improvement in liver fat. However, they're reported to cause weight gain and fractures in small bones and hypoglycemia. So you can give it to diabetics, but you have to remember that this is side effects. These side effects are associated with it. Obeticholic acid was a promising player in about 5 years ago, and this, unfortunately, this pyrosinide X receptor, nuclear receptor on the liver is supposed to regulate multiple processes such as inflammation, fibrosis, and metabolism of bile acids and glucose. However, unfortunately, the phase 3 trial showed that there was no improvement in the NASH score and compensated cirrhosis. Therefore, the study was halted and FDA did not give approval. This drug was also associated with severe urticaria or itching in about 20% of cases, and occasional liver failure was encountered. So this drug is undergoing now further investigation, looking at AI results of fibrosis scoring before dumping it as a non-useful drug. What is interesting is the GLP. Of course, you know how popular these drugs are in weight reduction, and the most important trial I want to point out is the Essence trial, which is now in phase 3. It began in 2021, plans to enroll 1,200 patients with NASH, and aims to assess the effectiveness of 2.4 milligram subcutaneous injection of semaglutide to show this is expected to be completed for analysis in 2028. The primary endpoint of this study is improvement in NASH without worsening of fibrosis and improvement in fibrosis without worsening in NASH inflammation. The primary endpoint of the study at 240 weeks is time to composite clinical event like failure of liver or the presence of need for transplant. Another study is being done with Mounjaro, which is a combination of GLP, GIP, and again, this study is not reported yet. So we don't have the data of whether these GLP agonists are actually reverse NASH. We do know that they are effective in weight loss and in prevention of cardiovascular events, but we don't have data on liver fibrosis. Another randomized trial published recently in New England Journal of Medicine, September of 2023, reports on a drug called pegozafermin, which is a long-acting glycosylated fibroblast growth factor analog, and also drops the hypertriglyceridemia. And this drug has shown good results with in 37% of treated patients. Resolution of fibrosis was documented versus 2% of those who received placebo. Common side effects included nausea and diarrhea, and we are awaiting phase 3 trial for this drug. The most important player, which is soon coming, hopefully, to the market as the only drug to be approved for treatment of NASH, is resmetirom. This drug is a selective thyroid hormone receptor beta agonist, regulating multiple processes in hepatic triglyceride and cholesterol metabolism, leading to decrease in intrahepatic fat content and therefore blocking the cascade of inflammation of liver origin. In the phase 2 clinical trial, patients treated with this drug had a significant reduction in liver fat content at 12 and 36 weeks compared with patients treated with placebo. And this was documented by MRI fat fraction, not by biopsy. In this trial, 20% of patients experienced diarrhea, and therefore resmetirom also positively affected lipid profile by reducing lipid in the blood and may secondarily prevent cardiovascular risk and mortality in patients with NASH. There is a NAFLD study which includes a huge number of patients of 1,200 patients randomized to receive this drug in 2 doses and a placebo, and the fourth arm is open label with resmetirom. And this is also non-invasive selection of patients based either on a previous liver biopsy or on their elastography screening. The primary safety endpoint for this study, including also measurement of LDL and reduction in their fat content by MRI fat fraction measurements. Points looked at were liver enzyme, FibroScan, MRI scores, and NASH biomarkers. The NASH trial, which is a separate trial, is looking at people with actual biopsy-proven NASH and randomized to either receive resmetirom or placebo. And this study was initiated in March 2019, enrolling 1,000 patients with biopsy-proven advanced liver fibrosis stage F3 or F2, and very few patients to stage F1. And it is randomization by giving resmetirom in a dose of 80, 100, or placebo. After 52 weeks of treatment, a second liver biopsy was performed. The dual surrogate endpoints were biopsy resolution of 2 points for NAFLD activity score with no worsening of fibrosis score, and a key secondary endpoint of lowering LDL. The phase 3 clinical trial has shown that resmetirom was effective in meeting both primary biopsy endpoint improvement, at least 1 stage of fibrosis without worsening of NASH score, and patients' resolution 2 points reduction in the ballooning and inflammation score in the liver. The FDA, therefore, based on this data, granted priority review for release of this drug on March 14, 2024, and we look forward to approval of this drug as the only effective drug for management of NASH, reversing liver fibrosis. In conclusion, NASH is evolving as the most common liver disease and indication for liver transplant all over the world, and particularly in our population. Weight loss so far is the only proven modality to reverse this condition, and detecting patients with fatty liver and early fibrosis offers a chance to treat obesity and cure NASH. Doctors in primary care setting should simply look at the abdominal girth and the BMI of patients and suspect this condition, refer them for further investigation by ultrasound and management of their weight. Specifically, we should focus on diabetics in our country who are involved with fatty liver in 68% of cases. The abdominal ultrasound is easy, non-invasive, highly affordable test to allow us to detect liver fat and liver fibrosis, and weight reduction diet can reverse early fibrosis. The problem is compliance of patients on long term. When diet fails, weight reduction is not achieved, drug therapy or bariatric surgery should be offered before patients progress to decompensated liver disease or die of the cardiovascular event. Many drugs are under current evaluation for management of NASH, but none are approved so far. GLP, GIP drugs are effective in weight loss and fat reduction, but data on NASH reversal is not available. It will be available several years down the line. Thyroid receptor drugs like resmetirom are effective in phase 2 and phase 3 trials, and I highly anticipate FDA approval in March of this year. Thank you very much for your attention. I look forward to meeting with you next meetings. Hopefully it will be personal meeting rather than on virtual meeting.
Thank you, Dr. Najah. Thank you for this interesting lecture. I have actually one question. How long we need to follow patient with NASH who we assume they achieve optimum weight reduction? And what factor you think from your experience we have to consider apart from lipid profile and liver imaging to assess these patients in the long-term follow-up?
You know very well that losing weight is easier than maintaining weight loss. Okay,
Yes.
so it takes diligent follow-up, and also the patient has to be educated to the risk of the weight regain. We know that there is no ideal way to keep the weight down. Even with bariatric surgery, regain of weight happens in 30% of cases. So it is the duty of the physician to tell these patients that once they achieve ideal body weight, the lifestyle has to continue. Exercise and low-carb diet and avoiding the highly processed foods is highly important. The more you stress it and the more the primary care physician maintains that idea in the mind of the patient, the better we're going to get. So far, we don't have the ideal answer. Now, where do I suspect fatty liver? Any diabetic should be screened. Like we screen for renal failure and diabetes, we should screen for liver failure or liver fat. It is also a surrogate marker for accelerated cardiovascular death. So a fatty liver is a big association with cardiovascular risk. And this is why when they develop cirrhosis, their cardiovascular risk is too high to allow easy transplant. They become very high surgical risk. So if you're going to do anything good, do it early before the disease kills them, either from MI or cirrhosis. The other problem I face in my practice is when I come to look for a donor for these people, most of their relatives are obese like them or diabetics. So it's very hard to get a living-related donor who will be ideal to be a donor for that particular patient. We faced the struggle. I ended up with one of my patients putting her relatives to bariatric surgery to lose weight to be able to donate liver in 2 cases.
So as I see your suggestion is to put more pressure on prevention of the disease or pick it early rather than to go into decompensating state.
Yes, we don't have an effective method of reversing advanced fibrosis when it reaches stage 4 or it reaches stage 3. We know that it is reversible in phase 2 and 1. And we know that we have proven even in our patients where I have done a liver biopsy on a patient, proven cirrhosis, then after putting her in bariatric surgery, the liver normalized. So I know it can happen if we catch the disease in early phase, but not in the late phase.
Hello.
Yes,
thank you very much, Dr. Najah. Thank you very much.
Can I ask a question? Hello.
Yes, Dr. Ghazi, go ahead.
Oh, yeah. Listening to Dr. Najah, certainly she is an institution. Liver disease is really is her specialty, and she is excellent. Hello.
Thank you, Dr. Ghazi. Mashkoor.
Thank you. I just want to ask you one question. It has been suggested by the American author, Robert Lustig. He's from the west of California. Anyway, he said that high fructose corn syrup, which is used in soft drink, is the most dangerous. Okay, most dangerous drug, the fructose, because the fructose metabolism only occur in the liver, and the fructose is really becoming the main consumption of the young people. Even he could see NASH in young people, and he says the only way to prevent it is to stop the soft drink if it is possible. And the whole idea is that NASH is spreading to the young people, and it is just like alcohol, you know, in its metabolism by the liver. Okay, will you on this?
Yeah, I totally agree with that. The youngest person I have in my clinic is 11 years of age. She was referred to me because of elevated liver enzymes, and she has a huge intake of fructose in the form of soft drinks and candy. Fructose is a cheap sugar, and the candy makers, the cookie makers, the cereal makers add it to the food because it's a cheap source of sugar.
Yeah.
Each can of Coca-Cola or soft drink contains 6 spoons of sugar. So imagine the load that is pushed to these people who drink soft drinks. And California has demonstrated that when they put taxes on soft drinks, the rate of fatty liver dropped. So I think it's time for our government to take a campaign to put taxes on these bad foods, limit availability to children in schools, which will make a huge difference in the future generation. I think all these so-called juices sold in our supermarkets are actually not juices. They are full of fructose and colors. So just be aware and read please labels on food items available.
Yeah, grateful to you. I think, you know, nobody could speak about the liver better than you. And I think if the government going to listen, is going to listen to somebody like you. I think it's very important. You raise your voice in this matter. Thank you.
Thank you, Victor.
Thank you. Okay.
Thank you. Really, thank you, Dr. Najah, for your presentation. It's very interesting, and to stress on the point for the thyroid receptors and its relationship with the fatty liver, it make the new tool to control the fatty liver.
It's very interesting that the liver has huge number of receptors for T2, which is this drug. T2 is not the usual thyroid hormone we think of, but the liver cannot store fat if you have enough stimulation of T2 liver. So therefore, you endocrinologists are going to be the leaders in the treatment of NASH. You know about thyroid hormone much more than us. What is very interesting is why do people do not have enough response to their T2 endogenously, and why they need this drug to activate it? Are they missing that receptor? We still don't know. Or is it resistance of that receptor? We still don't know the answer. But this drug, luckily enough, did not have serious side effects. It had transient diarrhea in a quarter of the patients, but by 2 weeks, usually it subsided.
Yeah. So if there is any other questions over here, Dr. Huda? Yeah. So by this, we can just try to close our conference today. Well, esteemed guests, ladies and gentlemen, as we reach the conclusion of the Internal Medicine, Diabetes and Obesity Conference, I wish to, like to extend my healthiest appreciation to the attendees, and even for the commitment to the delegates to stand all the time from the first day till today. Well, the sessions we have witnessed have been nothing short of exceptional, and presented the groundbreaking research findings, evidence-based practices, as well also the best expertise. So in closing, I would like to extend my deepest gratitude to everyone involved in making this conference a memorable experience. Let us carry the spirit of this event forward, working together to create healthier future for all. Thank you for all team who work hard for the organizing committee, scientific committee, beside also the support behind for IT and Mr. Ahmed from Education Plus and this team and Dr. Iman all over. And of course, we not forget all the chairmen of the sessions, moderators, beside the company who support sponsoring the first day about. And by this, we wish to close today, and we'll see you next year for the 7th IMDO conference. Thank you all.
Thank you. Bye-bye.
Thank you very much and bye.
Thank you. Thank you, Professor Rishad.